Okay. So good morning, everyone. On this vibrant Sunday morning, I, Dr. Archana Pate, Chairperson of IMA Maharashtra State Organ Donation Committee, extend a warm welcome to everyone. Respected President of IMA Maharashtra State, Dr. Suhas Pingade, sir. Honorary Secretary, Dr. Mangesh Pate, sir. IPP, Dr. Ramkrishna Londe, sir. President-elect IMA Maharashtra State, Dr. Ravindra Kutte, sir. Dr. Nitin Ambadekar, sir, who is Director, Public Health Department, Government of Maharashtra. Dr. Sujata Patwardhan, Madam Director, Roto Soto, Dr. S. Narayani, Business Head, Maharashtra, Fortis Healthcare, Mr. Santosh Marathe, Regional CEO, Apollo Hospitals, all the past presidents of IMA Maharashtra State, all the dignitaries of IMA Maharashtra State, the tall leaders, advisor of IMA Maharashtra State Organ Donation Committee, Dr. Arun Halbe, all the dignitaries, all the speakers, all the delegates. It's so wonderful to see everybody get together on this vibrant Sunday morning for a topic as important as organ donation and transplantation. With this in India, we know that there is a wide gap between the patients who need transplants versus the organ which are available. It is estimated that nearly 500,000 people with end-stage organ disease await organ transplant, but donation rate is quite low at some say 0.34 per million, some places it is mentioned 0.8 per million, which is extremely, extremely low. 90% of the people on the waiting list die without getting an organ. Government of India initiated the process of amending and reforming the Coma 1994. Subsequently, the amended act with many facilitatory provisions were notified in March 2014, but still this has not really resulted in increase in number of organ donations and subsequent transplantations. So there are many issues and challenges which have been noticed, which are considered to be responsible for this demand versus supply gap. Limited availability of NTORC, that is non-transplant organ retrieval centers and transplant centers, lack of awareness of concept of brainstem death among stakeholders, poor awareness and attitude towards organ donation, poor diseased organ donation rate, lack of organized systems for organ procurement from deceased donor, maintenance of standards in transplantation, retrieval and tissue banking, and high cost, of course. So hence it is imperative that we as healthcare professionals make ourselves aware of all aspects of organ donation and transplantation so that we can take better corrective measures at our end to create awareness and help towards reducing the demand supply gap. DAAN Fest is one step forward towards achieving this very goal, where IMA Maharashtra State, with its strength of nearly 47,000 doctors of modern medicine as its members, can be a major role player. It is an honor to welcome everyone who have joined us today for the inaugural session of DAAN Fest. Since I understand that today the election process, the election counting process is going on at IMA Maharashtra State Office, so we are going to be slightly reversing the order. Instead of calling the chief guest, that is President IMA Maharashtra State, towards the end, I'm going to be beginning with inviting him so that they are free to attend to other business. We are graced with the presence of President IMA Maharashtra State, Dr. Suhas Pingade, sir. Sir, I request you to share few guiding thoughts and declare the symposium open so that we can carry forward with the symposium.
Thank you, Dr. Archana. I welcome all those who have been named by Dr. Archana in her opening remarks, especially Dr. Ambadekar and Dr. Sujata Patwardhan, madam, and other guests and past presidents and other dignitaries of IMA Maharashtra State. It's a real human job which Archana has taken up and doing so well. So I say that this DAAN Fest Mahotsav is declared open and wishing you all the best. Thank you.
Thank you so much, sir, for your encouraging words and appreciative words. I now request our Honorary Secretary, IMA Maharashtra State, Dr. Mangesh Pate, to welcome the dignitaries and delegates on behalf of IMA Maharashtra State and address the audience.
Good morning all. Thank you so much. Honorable President Dr. Pingade sir, Dr. Archana Pate, all esteemed authorities and guests for today's this symposium. This is a very welcome initiative by IMA Maharashtra Organ Donation Committee, and its aim to reduce the numbers in the queue of the organ transplant is a very noble initiative, and it stands echoes the feeling of the IMA Maharashtra State, that IMA Maharashtra State works for people, which is the IMA for People initiative. Basically, today, very important, I will like to welcome very specifically to Dr. Ammadekar, a very highly ranked officer in the Maharashtra State. And let me tell, this symposium is being relayed across Maharashtra State, and all the Maharashtra State members, they are observing, watching this symposium. Dr. Ammadekar is the authority who has put forth the IMSA as far as the as far as the Maharashtra nursing home amendments are concerned, and they have echoed. He has echoed our feeling of opposing the IMA the amendment. So I welcome Ammadekar sir and other dignitaries and congratulate Organ Donation Committee. Thank you so much. Thank you.
Thank you so much, sir. Pingre sir and Patel sir, we won't be holding you much longer. If you wish to carry on with the election process, we will definitely understand. We are having with us President-elect of IMA Maharashtra State, Dr. Ravindra Kutte sir. Kutte sir, I invite you to please share your thoughts.
Good morning everyone. Am I audible, madam?
Yes, sir, you are audible. Yes, sir, you are audible.
Respected Dr. Suhas Pingle, Dr. Mangesh Pate, Chairperson Dr. Archana Pate, madam.
Sir, you are not audible. If you close your video, probably you will have a better audio quality. Sir, you are not audible. Sir, if you close your video, you will be audible probably.
Side leg.
Hello, sir, you are not audible.
Hello, is it audible?
Yes,
Hello?
you are audible, sir.
Hello?
You are audible, sir.
Hello.
Yes, you are
Yes.
audible, sir. Sir, may I invite you?
IMA Maharashtra State Organ Donation Committee has organized first virtual.
Sir, तुमचा आवाज नाही येत, sir. You are frozen. Sir, तुम्ही व्हिडिओ बंद केला तर आवाज ऐकू येईल.
Yeah, it's audible, madam.
Ha, it is audible, sir.
Yeah, Dr. Suhas Pingle sir, Dr. Mangesh Pate, Dr. Archana Pate madam, all the invited guests and members, Dr. Ammadekar, Dr. Patwardhan sir, IMA Maharashtra State Organ Donation Committee has organized first virtual symposium on organ donation and transplant. I congratulate Dr. Archana Pate madam, Chairperson of Organ Donation Committee, for consistently organizing various events and working methodically on it. Today's event will be a great academic feast, and my best wishes for this memorable DAAN Fest and awareness activity. Thank you very much.
Thank you so much, sir.
Thank you, ma'am.
Thank you so much, sir. It's an honor to have you here. It's an honor to have with us today Director of Public Health Department, Government of Maharashtra, Dr. Nitin Ammadekar, sir, who has spared time for DAAN Fest not only for the inaugural session, but he will also be taking a session, a very, very important session on how to register your hospital as NTORC, that is Non-Transplant Organ Retrieval Center, which is the need of the hour. So with this, we welcome a very, very warm welcome to you, Ammadekar, sir, and I request you to kindly put forward your views.
I just keep my video closed because.
Yes, sir.
Thank you. Good morning, everyone. Actually, I should have the participant, like those who are esteemed participants and all IMA members and presidents, those who are involved in this organ transplant. I need not to stress the importance of such type of awareness campaigns and the initiative what has been taken by IMA. So I'm really appreciative of it. what I only wanted to suggest is such type of awareness and participation in retrieval center is in need of an hour. Actually, as you may be aware, like hardly 10 to 15% of all these transplant are cadaveric transplant. So that is that would be actually an issue. So at this stage only, I'd like to say that we are there to anyway facilitate and reduce the procedural delays if any, and to support like people to get registered for NTORCs and all other like activities. So I must say, with this word, I'll congratulate all of you, and also say best luck to this conference, so that we can have more and more people joining this movement. Thank you, ma'am. Thanks everyone.
Thank you so much, sir. And we assure you that with a strength of 47,000 doctors and more across Maharashtra, IMA can be a very big stakeholder and a major role player in getting, NTORCs. We will be very happy to hold, the workshops of, because basically there is no awareness that if the hospital cannot be a transplant center, it can be an NTORC, and what are the guidelines for it, what is needed to be done for it, and we can work majorly towards that. So with your help, if we get help from Government of Maharashtra, we can give you doctors on board, and we can take a lot of workshops to create awareness about how to convert hospitals into NTORCs, sir. So with this, we'll be seeking your help into doing that.
Yeah, definitely, ma'am.
Thank you so much, sir. Yes, sir. Yeah. We warmly welcome Director Roto Soto, Dr. Sujata Patwardhan, Madam, here on this platform of DAAN Fest. Madam, it's a pleasure and an honor to have you over here. So please, over to you. Please do share your thoughts. Madam, you're muted.
Yeah, thank you, Archana, and I'm very grateful to IMA, to the IMA President, Dr. Suhas Pingle, and Honorary Secretary, Dr. Mangesh Pate, and the President-elect, Dr. Kutte sir, and Dr. Ambadikar. And Archana, I think the credit goes to you for taking so much initiative in organizing and keeping on organizing different symposiums and webinars on organ donation. And we acknowledge your importance in all these things. And I think definitely IMA has a major role to play with almost 47,000 doctors, which you mentioned. Apart from this, I think the main reason for organ donation not picking up in the state is apathy. Apathy on the part of doctors to not go ahead with identification, maintenance. It is not that we do not have patients of brainstem death. They are present in each and every hospital, including KM hospital. But the attitude of the people who are in charge of the ICUs and who are in charge of these patients is what has to change. And I think with your efforts, and we also, I would like to request you that if you have doctors who are expert in critical care, and when we have workshops on organ donation, taking care of the patient, brainstem death patient, his critical care is which is lacking in converting potential organ donors into potential brainstem death patients into organ donors. I think that is the main crunch. Public is always with us, and people who are like you and the general public is with there, but the stakeholders who are the actual players who are are in touch with the patients of brainstem death are not interested in the program. And we are working through it through ZTCC Mumbai and Roto Soto, but not getting much of a positive response. Anyway, with this, I definitely appreciate, and I'm happy that you are conducting this program and you are working towards NTORCs. I think that could be another major player in converting brainstem death patients into potential organ donors. All the best for the DAAN Fest of IMA Maharashtra and to the Organ Donation Committee of IMA. Thank you very much and mobilized by your act. Thank you.
Thank you so much, madam. And definitely, anytime such workshops are there, if you could just send us across the details, we'll make sure that it reaches out to the maximum number of our members. And 47,000 is just the number that you are seeing in Maharashtra, but we have more than 3 lakh doctors of modern medicine across India as members of Indian Medical Association. So we can actually go a long way if, more awareness is created.
Yeah, I have just one small announcement to make. Right now, from Monday onwards, we are having a MSW training program in Indore, and we'll be having a similar one in November for Mumbai. So, of course, I'll let you know in advance, and please do take part.
Sure, ma'am. Sure, ma'am. Yes, thank you so much, madam. And it is wonderful to see major transplant hospitals of Mumbai come on board for DAAN Fest, like Fortis Hospital, Mulund, Apollo Hospital, Navi Mumbai, Global Hospital, Parel, HV Desai Eye Institute, Pune. And it gives us great pleasure to welcome heads of 2 of these major organizations, Dr. S. Narayani, Business Head, Maharashtra, Fortis Healthcare, and Mr. Santosh Marathe, Regional CEO, Apollo Hospitals. With this, I invite Dr. S. Narayani, Business Head, Maharashtra, Fortis Healthcare, to please express her views.
Good morning, everybody. Dr. Archana Patil and all the dignitaries, a hearty congratulations for organizing this session and a session like this on a Sunday morning to create greater awareness about organ donation. And like you mentioned right in the beginning, the need for the organs far outnumbers the people waiting for these organs. And as much as, and I think it is not because of lack of efforts of creating awareness, a lot has been done by all of you all in this area. Dr. Tara Patwadan is there, and we are all aware of how much she has taken forward this movement. But yet, as much as we do, there's so much more left to be done. And I do think there has to be greater awareness in the hospitals, in the critical care units. I completely resonate her thoughts on this thing about apathy. While everybody is aware, for some reason we do not really still have a mechanism where all hospitals are able to pick up those patients who are potential donors and counsel. I do think there's a significant awareness in the society today, and we must remember that Maharashtra has probably in some ways even overtaken Tamil Nadu, at which at one point of time was the lead in organ donation, but we have a long journey to go. And I'm very happy that, as you know, a lead in Fortis Hospital, we've always been committed to the cause of organ donation, even before coming to transplantation. And our centers, which are not transplant centers, also participate in organ donation. So we make this a very active effort. And at any point of time, wherever there's a need to help out in any way in terms of training or in terms of participation and creating awareness, we would be more than happy to join hands with organizations like yours and give support to this cause, because we truly believe in this. And there's a lot which has been done by all of you all, but then there's so much more to do to really get to where we want to. So thank you very much for having me on this session today, and congratulations and best wishes to you all once again.
Thank you, Dr. Narayani. Thank you for being here on this Sunday morning for DAAN Fest. And it's a pleasure to have you here. With this, we also have gracious presence of Mr. Santosh Marathe, Regional CEO, Apollo Hospital. I request Mr. Marathe to please say a few words.
Thank you, Dr. Archana and the team. I think it's a wonderful initiative, and thank you for calling us to be gracious enough for this event. I think organ donation is a very social activity, as we see from Apollo's point of view also, and we are really thankful for the kind of efforts that IMA, ZTCC, Roto Soto, the public health authorities, especially the Green Corridor team, which helps us in retrieving and transporting organs, has been doing some amazing work in terms of this thing. In the last 2 years, as we see, COVID has been a little dampener. But despite that, I think the organ donation movement still continues to gather momentum. Within the Apollo ecosystem, we are privileged and honored to undertake almost 500 transplants as on date. We do liver, we do kidney transplants, we do heart, we do cornea. Very recently, we have got the license for lung transplant also, and very soon we will be doing our lung transplant. As a part of increasing enhanced capability and awareness, we have integrated almost 8 outbound centers in remote parts of Maharashtra, where our liver team from Apollo hospitals goes and conducts liver transplants at the remote 8 locations. So this is something which we will continue to contribute on the cause. almost 10% of the transplant that we have done as on date have been contributed through cadaver, and we have been offering organs to the other hospital units also. And I think public enhanced awareness is the key. And I think there is a momentum. People are well aware, well educated, and it's a very good social cause. And we are definitely very honored and privileged to be a part of this great activity. And once again, a big thank you to IMA for organizing such kind of events, which really gathers momentum and enhance the overall quality of life and awareness for the general masses. Thank you again for the invite.
Thank you. Thank you so much, Mr. Marathe, for being here on this morning. Our IPP, Dr. Ramkrishna Londe sir, was not there initially when we started with the inaugural session. So, Londe sir, could you please say a few words and then we move on towards the sessions? Londe sir? We acknowledge the presence of past presidents of IMA Maharashtra State, Dr. Ashok Tambe sir, Dr. Arun Paude sir, Dr. Milind Naik sir, Senior Vice President, Dr. Prakash Marathe sir. It's absolutely wonderful to see, all the stalwart leaders of IMA Maharashtra State also attending on this Sunday morning. And I'm sure together all of us are going to go a long way in creating awareness. So thank you all the dignitaries for all the kind words of support and appreciation. With this, we come towards the end of this inaugural session, and we thank all the dignitaries for sparing their precious time to grace this event. Before we end this session, on behalf of IMA, we reiterate our commitment to work extensively towards creating awareness for organ donation at all levels. And with this, thank you everybody for being here for the inaugural session, and we move towards the most awaited scientific sessions. Our first two speakers are already here present with us. So we begin with our first session. A potential organ donor is defined by the presence of either brain death or a catastrophic injury to the brain, which could progress beyond reversibility and may fulfill brain death criteria. In India, the death rate is approximately 7.3 per 1,000 people per year, with a population of 1.38 billion. So the actual numbers of deaths per year are staggering. Out of this, nearly 32.1% of the total registered death occur in institutions. So only and only if we were more aware of the criteria of brain death and what to do and how to identify a potential brain dead person who could become a potential organ donor. And on this background of increasing organ demand compared to the organs available for transplantation, proper identification and care of potential organ donor could go a long way in reducing the demand supply gap. Our first session today is identifying potential brain dead donor and proceeding thereon. And to speak on this, we have Dr. Akshay Challani. Please allow me to just put on the PPT. All right. So Dr. Challani has done DNB General Medicine, FNB Critical Care Medicine, FCPS Medicine, MNA, MS, FICP. He's consultant physician and intensivist. He's medical advisor and critical care specialist at Apollo Hospital, Navi Mumbai. He's chairman Mumbai ISCCM and executive committee member West Zone ISCCM. A warm welcome to you, Dr. Challani, and the session is all yours. You've been made the co-host, so you'll be able to share your screen.
Thank you, Dr. Archana, and thank you, Indian Medical Association and Dr. Archana's team for giving me this opportunity. Actually, I'll talk about this identifying the potential brain dead donor and proceeding thereon. As already a few previous dignitaries are already mentioned here, there's a lot of disparity between what we need, what is the demand, and what is the supply. So the idea of this talk is to just sensitize you whenever you see a patient as a physician, as an intensivist, or a critical care person, whoever comes to your ICU, what exactly is to be done, how exactly you need to identify the potential brain dead donor. And once you identify what needs to be done, I'll just talk on that. I hope my slides are visible and my voice is clear.
Yes, yes, yes. I request everyone to please mute your themselves. Dr. Challani, I'm just going to mute everybody. Please unmute yourself.
Yeah, this is very classical scenario whenever we come So I just start with what we do daily and what we come across. This 44-year-old man was brought to the casualty following a loss of consciousness. The moment he came to the casualty, we found that this patient is GCS is low, that is E1, M4, and V1. In view of poor GCS, he was mechanically ventilated. When did a clinical examination, we found that the pupils are unequal and reactive. His heart rate was 98 and the BP was 168/90. So as a routine investigation, we did this and we found that the CT showed significant bleed in the brain. So in the ICU, next we did a routine investigation, neurology, and the neurosurgeon consultation was done. So we take an opinion, started to talk to the relatives, and then all treatment started day 3, day 4 in the ICU. After 3 days, there was no significant improvement in the patient's condition. His GCS has worsened. It remained E1, VTM, M1, even after stopping the sedation for more than 2 days. And the pupils now fixed, not reacting to the light. Now, this is a classical scenario. 44-year-old man comes to the ICU, intracerebral bleed, significant bleed. Now is not waking up. Pupils are almost dilated and fixed. Now, the question is what next? As a physician, suppose you are treating this patient, what next? What you need to do? Is this a brain death, or this is a whole brain death or brainstem death? As Dr. Archana has rightly said, what exactly is the brain death? Basically, it is a irreversible coma, which you have ruled all the potential things which can cause a coma. This determination of brain death requires identification of the proximate cause and irreversible of coma. So whenever we talk about the brain death, it should be very clear. You should know why the patient is brain dead. So in this case, we know that the patient has an IC bleed. That is the reason he is a brain dead. So whenever we, in the context of brain death, or whenever in the context of the organ donation, the prerequisite or the basic things what you need to know the cause of the brain death. Unless and until you know, it's very, just keep a very high threshold to label the patient as a brainstem death or a brain death. I think my next speaker will talk how to identify and all that. But to just summarize, death, the deceased person means a person in whom the permanent disappearance of the all evidence of the life occurs by the reason of brainstem death or a reason of cardiopulmonary arrest after the live birth has taken place. And the brainstem death means the stage at which all the function of the brainstem have permanently and irreversibly ceased. One thing is pretty clear when you talk about the brainstem death, there is a cessation and which is irreversible and permanent. It should not happen that there is a hypoglycemia, the patient looks like drowsy or comatose. Once you give a sugar, the patient become conscious. That should be permanent and irreversible. So once we identify, or once we know that it's probably the patient is a brain death, what next you need to do? You just need to involve your transplant procurement manager or transplant coordinator. Every institute, by and large, those who are dealing with brainstem death or organ transplantation, they have to have the at least medical social worker or transplant coordinator. Or as per your hospital policy, you need to have the transplant coordinator. Now, some people might ask, is it compulsion that we should have social worker or we should have the transplant coordinator? By and large, in Maharashtra, or when we talk about the director of health services, Dr. Archana has already mentioned there is one entity which is called as non-transplant organ retrieval centers. By and large, suppose you have your ICU or you have the operation theater, this nursing home, this hospital, this institute should be registered with the director of the health services or concerned state authorities. Now the issue, why it's important, basically if you see, there are very few centers, as already spoken, the number of organ available and the number of organ demand, there is a loss of disparity. So by and large, those hospital or those nursing home, they don't have the infrastructure. They should have at least there is a provision, or at least there is some infrastructure to get the organ retrieval. So what I mean to say, as the large number of brain death occurs in the non-transplant hospitals, by and large, if you see all big hospitals, corporate hospitals, they have the facility for organ donation, transplant and all that, but it's not possible in the sub-center of the nursing homes or local hospitals. So what these hospitals are permitted to certify the brain death as per the procedure and then conduct the organ retrieval for the therapeutic purposes, but not permitted to perform the actual transplantation. So what I mean to say, suppose there is a nursing home, they have the ICU and they have the operation theater, they can certify that the patient is brain death, but the moment they certify, they can retrieve the organ but not do the transplant. So they need to shift, or they can transfer the organ from one hospital to another hospital where the transplant has been done. The state of Maharashtra has passed a resolution making it mandatory to certify the brain death. It's very clear now. All these hospitals, nursing homes, they have the system to certify, identify those who are the brainstem death. And it is mandatory now for all the NTORC, that is transplant organ retrieval centers and authorize the transplant centers in the state to certify and notify the brain death cases to the Zonal Transplantation Coordination Committee. Once you know the patient is dead, or once you anticipate that the patient has a brainstem death, you need to inform the concerned authorities. Now the question comes, as already suppose the patient is dead or brainstem death. We'll talk how to identify and all that in the next topic. But once you know that the patient is a brainstem death, you need to communicate. Now to whom will you communicate actually? So there are a lot of, if the patient has make his will or organ, already there is an organ donation card, then we know that this is very clear that the person who died or the patient who is brainstem death, he has his will and he wanted to donate the organs and all that. But now the problem, once the patient is brain dead, whom will you talk? Legally, you need to talk to the spouse, either husband or wife, son or daughter, if they are more than 18, or parents. Please remember, suppose there is a head trauma or there is a medical legal case, you need to involve the local police when there is a medical legal case or trauma or injury or you suspect the foul play. Now the important thing, we know that there is an organ demand, a lot of organ demand, but whether it makes, you can't be too early to get the organ, but at the same time you can't be too late to retrieve the organ. So whether in a specific time, once the patient comes to you or patient comes to your hospital, whether in a time where you can think or when you can need to do the brainstem death. Dr. Rahul sir will talk about the brainstem death, but what is the time period? You need to wait or you need to at least give some time to make the things very clear. The moment the patient comes, the things are not very clear. It's possible sometimes it's a reversible cause, the patient might wake up. But by and large, this is recommended or this is expected. So once you think or once you anticipate the patient is brain dead, how much time you should wait? Suppose there is a major neurosurgery or aneurysm bleed, at least you wait 4 hours after that surgery to identify certified death. Suppose there is a head injury, you need to wait for 6 hours. Spontaneous IC bleed because of subarachnoid hemorrhage and all that, need to wait for 6 hours before you do the test. Brain hypoxemic injury, whether it is a cardiac arrest or drowning, at least 24 hours are recommended to do the testing. And drug intoxication, at least 2 days or 3 days you need to wait before you make it very clear that the patient is brainstem death. Now there is one caveat actually. Suppose the recipient is, suppose there is patient number A and he has a recipient. He is a 45 or less than 45-year-old. I'm talking about the recipient. And now when we come to the donor, so this fellow suppose requires kidney or this fellow requires a liver, the person who is going to donate, whether there is any cutoff or whether there is any age cutoff for which from where you can get the donor. Ideally, this is not very compulsory. It may vary from patient to patient, but ideally, if the recipient is less than 45-year-old and if he wish to get a kidney or liver, ideally we expect the person who is going to give a kidney, his age should be not more than 60. In the case of liver, not more than 60. Pancreas up to 7 days or 50 years old. Heart, ideally we expect it should be not more than 45 and the lung 60 to 65. This is because ultimately whomever giving the organ, there should be sustainability. It should not happen that you just give a kidney of a 90-year-old man, anyway he's going to die and now this problem happens. So by and large, these are the cutoff criteria actually. This is not very strict, but you just need to keep into the mind. So ultimately when we identify, suppose this patient has a potential brain dead and you just do the testing, but by the time you do the testing, we need to talk to the relatives till the consensus reach. Sometimes it's possible in the family member, if you need to ask the son, daughter. Sometimes son says yes, the daughter says no. But what you need to give, just give enough time for the relatives to come on the same page. They should be on the same. Any of the relatives says no, then you can't do that. So till that time, you just need to manage the donor. And it is very important to manage the donor because ultimately how you manage it subsequently it reflects in the person who is receiving that donor, because the life of that donor kidney, donor liver depends upon how you manage the donor at the time of brainstem death. So generally intensive critical care principles you need to follow. As by and large, I expect or just see that the time from the brain death to retrieval surgery should be as less as possible. You can't delay too much actually. Now, what are your goals? When the patient is in our ICU, what are your goals? By and large, heart rate, you just try to keep in between 60 to 120, mean arterial pressure, systolic pressure more than 70, mean arterial pressure more than, systolic blood pressure more than 70, mean arterial pressure 70 or more than that. CVP, now by and large, we don't do that, but just see that the patient is adequately volume resuscitated. Electrolytes, you mentioned in between 130 to 150. Try to manage this potassium, magnesium, phosphate. Urine output should be more than 0.5 to 3 ml per kg per body weight, so approximately 100. Always try to see the saturation more than 95 and the sugars are less than 150. Now coming back to the same patient, now almost 3 or 4 days are over. There is no significant in the patient's condition related not yet decided, but sodium now went up to 158. He's passing excessive amount. So what exactly is this? what is the plan now? Why the sodium is going up? How to correct? If the patient is hypotensive, which fluid you will give? These are the common questions we just come to across when we manage this brain dead patients. So what next? Basically, why the sodium is going up? There is one entity which is called the central diabetic insipidus. By and large, when you manage the organ donation, frequently will come across this entity. So any patient with the brainstem death in your ICU, if he's passing urine more than 250 ml for consecutive 2 to 3 hours, you check the sodium, which is more than 50. Until proven otherwise, you think of diabetic insipidus. At the same time, you can have this hypokalemia, hypomagnesemia, hypophosphatemia. Patient is dehydrated. And so how do you treat this central diabetic insipidus? You treat it with either vasopressin IV or desmopressin. When the patient is mechanically ventilated, mostly brain dead, it's difficult to give the nasal spray. But one of the options to you can explore this option. So what exactly, why this happen? I'll just talk about this. What is the pathophysiology of the brain dead patients? There is a raised ICP, herniation, then infarction, loss of central vasomotor control, loss of dyspeptic drive. There is a hypothalamic pituitary axis is completely collapsed. There is massive release of inflammatory cytokines, interleukin 6, 8, optimizing factors. The pituitary hormone are not secreted properly, like vasopressin, thyroid hormone, endocrine deficiencies, diabetic insipidus, and relative adrenal deficiency. We talk about the diabetic insipidus. What are the other physiological metabolics you see in the patient who is a brain dead? There is a hypothermia because of loss of thermoregulation, reduced metabolic heart rate, excessive heat loss, and loss of protective mechanism such as vasoconstriction or shivering. Just we talk about the hormonal dysfunction and anemia, coagulopathy, and immunological changes. This anemia because of more of the release of the inflammatory cytokines, and for the resuscitation, first 1 or 2 days you give a lot of IV fluids. That may be one of the reasons for the dilution coagulopathy. General care as a routine care till the patient decide whether to give or not to give the organ donation. The routine care, what you need to do, just see that you take proper utmost aseptic precautions, take care of eye, because it's possible sometimes this patient is brain dead or brainstem death. We tend to ignore the eye care and all that, the frequent turning of the patient so that there is no infection, no pressure source. Keep on doing the RT feeds, because subsequently it found that those patients who are properly have proper nutrition and RT feeds, they generally do well. And monitor the arterial blood pressure, sugar, pulse oximetry, temperature. Core temperature, when we talk about it, should be either esophageal thermometer or the rectal temperature. Please remember whenever you, yes, I'm just finishing, sir. Yeah, what are your goals? Rule of 100, just try to keep the BP more than 100, urine output more than 100 ml, saturation near 100, hemoglobin around 10, and the blood sugar less than 100. So arrhythmia, you just, whenever there is arrhythmia, use standard therapy. In the bradycardia, generally atropine glycopeptide doesn't help, so you can explore the option to use the pacing. Still the patient is not doing well, patient has hypotension, the relatives are confused, not yet decided what to give the brain or not. What are the reasons for the hypotension? Mostly it's diuretic, hyperglycemia, diabetic insipidus, and cold diuresis. So how to maintain the BP in the potential brain dead organ patients? IV fluids, you can't give this normal saline and routine fluids because the sodium is very high. So how do you maintain? You just give norepinephrine, vasopressin, or dopamine. Please remember, when the heart function is less, EF is less than 45, you can explore the option to give the hormone replacement therapy or hormone resuscitation. So what are the options? This American Society of Transplantation and the American Transplant Surgeon, they have endorsed hormone resuscitation therapy. This is not evidence, this is not robust data, but you can explore the option. This data is just to show that number of patients who received the hormone therapy in the form of thyroid, they did little well as compared to those patients who did not receive the thyroxine. The option being here is the steroid and the thyroid hormone. Steroid, those prefer those in the patients who are going for the lung transplant. Now, still the patients are, last 5 minutes, sir. Still the patients are not decided. The relative are saying that patient is moving the legs, he is not brain dead. So which are the things which are not compatible and compatible with the stem death? If the patient has a spinal reflex, he has a sweating, blushing, tachycardia, patient has a normotension without pharmacological support and absence of diabetes, it doesn't mean that the patient is brain dead. With this, we can have brain dead. But please remember, if the patient has a seizure or patient is decerbating or decorticated, he is not a brainstem death. Now relatives give consent, they say, yes, we are ready for the consent, but now the problem is that the patient gets the fever. So what to do actually? Do you wait or do you go ahead with the organ transplantation? Please remember that infection is a major concern. Try to see that when you transplant the organ, it is infection-free. Do multiple blood cultures till you prove that the patient is non-infective. Or suppose there is a colonization of the bacteria with some organs, you can't transplant that organ. Finally, the organ donation is done: kidney, liver, pancreas, and heart, and that's all from my side. So basically, in a nutshell, what I mean to say, take a proper consent of the patient, relatives, and try to manage the patient rule of 100, please remember BP more than 100, systolic blood pressure more than 100, heart rate around 100, saturation around 100, hemoglobin around 10, and output around 100. So this is my last slide actually. So recycle yourself and become an organ donor. And this is the word from Wama. The definition of death and the establishment of the point of death needs to be addressed in the era of resuscitation organs. That's all from my side, and compliments from Apollo Hospital. I'll be happy to answer any questions.
Thank you. Thank you so much, Dr. Challani. That was indeed a very elaborate session and it was wonderfully taken. If anybody has got any questions, we can take 2 or 3 questions. Either you can ask it in the chat box and I'll take it up for you. And sir, if you could just stop the screen share or otherwise the delegates can just raise their hand and I'll invite you to ask your question. So if there are any questions, we can take it up. There should be many questions actually, because if just this concept of brain death is understood, then it is like one big step towards creating awareness, So if there are any questions regarding this, how to identify a potential brain dead donor is what we are trying to understand from this first session. So if there are any questions, please do ask. Okay, so just a question from my end. I mean, before we move towards the brain death certification, actually how it is done, which Dr. Pandit will be covering. But in case what you covered was how to sustain the brain dead donor. But what I want to ask you that in case somebody, now we are talking about NTORCs, transplant centers, but they are very, very less in number. There are major number of hospitals which are not NTORCs, which are not associated with transplant and anything in any way. So in case a doctor over there who's treating intensivist feels that the patient is, potentially he could be a brain dead patient, the patient is on ventilator, and they feel that because as per the medical ethics, as per the THOA Act, unless you are going to think in terms of organ donation, you cannot declare the patient as a brain dead patient. So what is that hospital supposed to do? What are those hospitals supposed to do? Can you just enlighten our members on that?
Yeah, basically to ask your question, the brainstem death is done in the context of only organ donation. Suppose there is no plan of organ donation, you can't talk about the brain death and you can't do the testing. Now, suppose you have the hospital where you think there is a potential organ death, there is a potential brainstem death patient, and your hospital is not recognized for the organ transplant. So there are 3 options. One, you just select the nearest hospital which is doing the transplant routinely. You can shift the patient there. That is the first option. That is a better one. Second option, what you can do, you have the qualified doctor, neurologist, neurosurgeon. You can certify the brainstem death when the relatives give the consent. Once they certify, if you have the operation theater or if you have the obviously, suppose there is a, I'm assuming that suppose you are certified, you had a patient who has a potential brain death, then you have the ICU. Suppose you have the ICU and the operation theater, then 2 qualified person can certify death. You can, the person who is doing the transplant from the nearest hospital, they can come retrieve the organ and take the organ. Third, suppose you don't have the operation theater, it will be difficult. So the best option, my suggestion to you, shift to the hospital where it is less time consuming, nearest to you, and they are doing routinely the transplants. That is the ideal way.
Yes, so this is for everyone. I think this should be the take-home message from this first session, that one, identification of brain death is very, very important. Second, if you identify a brain dead donor, if a person, rather, I won't say a brain dead donor, but a brain dead person who could become a potential organ donor, please see to it that, that death is not wasted, or those organs are not wasted. See to it that the Roto Soto are informed, or because they are the nodal agencies who can help you, in getting everything coordinated, and they can get you in touch with the NTORCs or the transplant hospitals, and probably they can take it forward from there. But if you think of transferring the patient to an NTORC or a transplant center whom you think is probably a brain dead patient on ventilator, please see to it that you put in all your efforts to sustain the cardiorespiratory functions and all the metabolic functions of this patient, so that the patient reaches the transplant center safely and something can be done about those organs. So with this, thank you so much, Dr. Challani. It has really been a pleasure to listen to you. And with this, Please allow me to present you with a certificate of appreciation for taking excellent session for medical professionals on identifying potential brain dead person and proceeding thereon during organ donation and transplant symposium DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. And the certificate, definitely we will be posting it to, or rather sending it to you on mail. And we move
Thank you.
on to
Thank you very
our,
much.
we sincerely thank Apollo Hospital Navi Mumbai for their educational association with this session. Moving on to the next session, brain death is a permanent cessation of all functions of the brain in which, though individual organs may function, but lack of integrating function of the brain, lack of respiratory drive, consciousness, and cognition confirms to the definition that death is an irreversible cessation of functioning of the organism as a whole. Brain death is not promptly declared due to lack of awareness and doubts about the legal procedure of certification. And of course, there is lack of awareness otherwise about the brain death per se. So what is brain death certification and what are the common pitfalls associated with this? To enlighten us on this, we have with us Dr. Rahul Pandit. Please allow me to share my screen. Yes. So Dr. Pandit is senior intensive care consultant with over 2 decades of experience. He's director critical care medicine and ICU at Fortis Hospital, Mulund, fellow of Joint Faculty of Intensive Care Medicine, Australia. He also has European diploma in intensive care medicine. He plays lead role in setting up ICU policies, protocols, and patient care algorithms. He's ex-vice president of Indian Society of Critical Care Medicine. He's visiting consultant at Bathurst and Wagga Wagga-based hospitals, New South Wales, Australia. His areas of interest include critical care echocardiography, trauma, neurotrauma, obstetric emergencies in ICU, and sepsis. It is always a pleasure to have you on, our all organ donation awareness programs, Dr. Pandit, and the stage is all yours. Please take forward the session.
Thank you very much, madam. Thank you for the kind invitation from the Indian Medical Association and the Organ Donation Committee of the Indian Medical Association. It is indeed a pleasure to be always coming up and talking on the IMA platform. May I just take 1 minute to actually talk about the previous question which was there? So,
yes, sir.
It is not true that we should be only talking about brain death in the context of organ donation. If you are dead enough to donate, you are dead enough to be declared. And that has already happened as a form of legislative change in the state of Kerala. And if at all a person goes to the court will take a very bad cognizance of the fact that you have a brain dead patient, but we haven't declared the patient dead. So I think we as clinicians should identify that the government and the law of Indian government has basically given 2 scenarios for death. One is circulatory as well as the brain death. And in either of them, whether there is a consent for organ donation or not, it is our primary duty to actually declare a patient dead. Even the Maharashtra government has taken out a GR that every brain death should be reported to them, irrespective of the context of organ donation. So I think the first important thing is to decouple the 2 together. Let's just talk about brain death here right now. And then in the second part of your symposium, which starts after me, is the organ donation part, where you have different organs. So I think first let's understand the brain death, and then we can talk about organ donation as we come to. Thank you very much. Are my slides visible?
Yes, they are visible.
Thank you, madam. Okay, so the Indian law, the Transplantation of Human Organ Act, we all know it was basically formulated in 1994. And what did it do? It recognized brain stem death. I think that's the most important thing to understand, that when we talk about brain death in India, we are having a very much a colonial kind of approach, which is the UK based approach, which we follow the brain stem death. Some of the North American countries, including United States of America and several states there, follow the whole brain death. So that includes a lot more in form of certification, especially the ancillary test. But for us, just the clinical examination is fine. The definition of death has already been covered by Akshay very nicely. I just want to highlight to the green and the blue box at the bottom. In cardiopulmonary sense, at any time after live birth has taken place, and brainstem death means stage at which all functions of brainstem are permanently and irreversibly ceased. We know the brain anatomy. This is a cerebral cortex. This is the brain stem. And this is what basically we are trying to see, whether we can identify the irreversible loss of brainstem function. So how does the brainstem death happen? So we all know that there is some form of a neuronal injury, whatever it could be. That neuronal injury gives rise to neuronal swelling. That neuronal swelling then raises our intracranial pressure because brain is a fixed compartment inside our skull. As the pressure increases, the flow of the blood into the intracranial starts decreasing, which then further leads to a neuronal injury again. And a time will come where the intracranial pressure then rises above the mean arterial pressure, which becomes incompatible with life. And this is how the patient will become brain dead. So the first step in identifying and then proceeding for the test for brainstem declaration is to identify if there is an underlying cause for a patient to be brain dead. So there are few possible causes which could basically progress to brainstem death, not limited to the slide which I am just showing. You could have a trauma, anoxic brain injury, you could have cerebral hematomas, infarctions, subarachnoid hemorrhage, so on and so forth. I think what's important is that we should be very clear that is there a potential cause for brainstem dysfunction? And if there is no potential cause which is seen, just be cautious, take a step back, and then start looking at confounders, whether there are any confounders or not. So what are the confounders? We need to be very clear about the confounders before we proceed on to the brainstem circulation there. So the first confounder is, which fortunately is not seen in India that much, but in the intensive care units is not very uncommon, is severe hypothermia. If your temperature is below 32 degrees centigrade, you can never declare a patient brain dead. So you are not dead until you are warm and dead. That's the concept which we follow in the cardiac resuscitation as well. Similar dictum is followed in the brainstem declaration as well. So what happens is that because the patient's brainstem function have ceased, there is no shivering mechanism and temperature control mechanism, which all happens in the brainstem. The patients actually cool down very quickly to the ambient temperature of the ICU, and it's not uncommon to see them severely hypothermic. Akshay said, always measure a rectal or esophageal temperature, which means core temperature should be measured. Severe hypotension below 100, it's an absolute no. At least try and keep the blood pressure of systolic of 100 millimeters of mercury. You have to effectively rule out drugs, alcohol, any recent poisons, recent use of sedation, neuromuscular blocking agent. You can use a train of 4 reaction to see a peripheral nerve stimulator to see if the neuromuscular agents have been acting or not. And severe electrolyte abnormalities, especially hyponatremia, which can cause severe coma, hypercalcemia, hypoglycemia, acid-base anomalies. So it's important to have a normal-looking ABG with all of these parameters being there. So these are the preconditions. Practically, you need to have a core temperature measurement. You need to rule out drugs, peripheral nerve stimulator, and as I said, do a good ABG and make sure that the ABG parameters are normal. Now, how do you establish brain death? The actual certification process. You do 3 things. You look at the irreversible coma. You look at irreversible loss of brainstem reflexes. And then the third one is you look at the cessation of respiratory center function. There is a 4th one, which is demonstration of cessation of intracranial blood flow. Unfortunately, this can only be done if you're not able to do the first 3 for some reason. And one of the good reasons would be that you have a head injury as well as a cervical spine injury. The patient would be apneic because the cervical spine transaction above the C4, C3 level, and hence he may not be breathing. So apnea test may not be possible, for example. But unfortunately, the number 4 is not a part of our TOHA Act. So currently, we are left with just clinical declaration. Ancillary test or cessation of blood, intracranial blood flow demonstrated radiologically is not allowed. Now, who does the testing? The testing can be done after 4 to 6 hours, as Akshay has already demonstrated that. Testing is done by 2 doctors who can be either a neurologist, intensivist, neurosurgeon, or an equally qualified doctor who is certified to be on the hospital brainstem death panel. So there is a hospital brainstem death panel which has to be approved by the DHS. You could have physicians also, you could have intensivists also, you could have neurologists. 2 more people observe the process, and they are the primary physician and the hospital in charge administrator. The 2 doctors who do the test do it at 6 hours interval, and the rest of the 3 observe 1 doctor performing the test all the time. So both the doctors, all 4 doctors have to be present to both the test. So let's take 1 step at a time. So demonstration of coma. Absence of a motor response to a central deep painful stimulus is what we need to look at. Beware of the local spinal reflexes caused by spontaneous stimulation below the central deep painful stimulus. So what's the central deep painful stimulus? You have to have a painful stimulus given in the cranial nerve distribution, where the afferent and the efferent both are in the cranial nerve distribution. So you have the medial canthus of your eye, or you can have a jaw lift. Both of them are actually trigeminal, afferent and efferent. So that's the central brain deep painful stimulus. If you do a sternal rub, yes, it's a painful stimulus, but remember, you will be actually stimulating the spinal cord, and thereby you may actually have a spinal reflex, and you may get a false reading, believing that the patient moved when you had a spinal reflex given to them. So that's very, very important to give within cranial nerve distribution. Then you test for the brainstem reflexes. I'm just going to quickly go through that because this is just first MBBS stuff. Pupillary reflex, people should be fixed and dilated, no reaction to light, direct as well as consensual. The corneal reflex should be absent in both the eyes. Your gag and cough reflex, because these patients are intubated, you just put up a tongue depressor and do a gag reflex at the back of the throat and insert a suction catheter through the carina and make sure that they are not coughing. So gag and cough should be absent. The vestibulo-ocular reflex, which is done by injecting cold saline, ice cold saline in both the ears and looking for deviation of the eyeball towards the same side, should be done. But we should be testing and making sure that the ear does not have any wax in it. Otherwise, the cold saline will not hit the eardrum and you may get a false reading. Only after all of these tests have been done, you should come to the documentation of apnea test. This seems to be the most complex one. Let's try and simplify it a little bit. So always pre-oxygenate this patient. Practically what I do is when I start doing the testing, I start patient on 100% oxygen around 20 minutes before that. Do a ABG just before I start the testing. I disconnect the patient from mechanical ventilation if the ABG parameters allow me to do, as I've already covered that before. And then try and insert a catheter through the endotracheal tube to keep the saturation about 94-95% using 4 to 6 liters of oxygen. And for every 1 minute of apnea, your CO2 will rise by around 3 millimeters of mercury. So your aim is that you start with a normal CO2 of around 40 and wait for the CO2 to go above 60 millimeters of mercury. And that would take approximately 10 minutes, 8 to 10 minutes. There is another rule which says 20 millimeters from the baseline. That 20 millimeters from the baseline is only taken up for patients who are CO2 retainers, not patients who have a normal CO2. So if you are not able to get the patient CO2 down because the CO2 baseline is around 55, then you wait for it to go up to 75. That's how you basically declare the patient that the patient's apnea test was positive. This is how the apnea test is done. You keep on monitoring, you do an ABG, and once the two specialists complete the test, the death time is confirmed as the end of second examination. The form is signed by 4 doctors, both the specialists who have performed the test at 6 hours interval, the primary specialist and the hospital administrator in charge. This is how the death is confirmed. Once the death is confirmed, the consent for organ donation can be taken up. I think this was again covered very well by Akshay. What are the signs compatible and incompatible with brain death? I'm now going to go across and talk about a little bit of pitfalls. So it is important to diagnose brain death. As intensivists, as physicians, it is our primary responsibility to diagnose death. You need to decouple it with organ donation. And yes, if organ donation happens, it is a part of the byproduct of declaration of brainstem death, and it can save up to 8 lives or even more in terms of tissue and other things. Rule of 100, I might just want to add a few more things for rule of 100. Measure sodium and potassium every 100 minutes. Keep PaO2 around 100. Peaks to continue at 100 mils an hour. Keep urine output around 100 millimils an hour. And keep temperature of around 98.6 degrees, which again corresponds to just near 100. The rule of 100 is very, very important in maintaining a donor. Is age a bar? Absolutely not. Age is not a bar. You can declare patient of any age as brainstem death. Pediatric criteria are different. I am not covering them in this. Infection, leave it for the transplant team to decide whether they would accept an organ or not. There are some malignancies which we may not want to do, but again, you can always ask us or the ZTCC or the Roto-Soto to see if you would like to proceed with some form of malignancy. Some of the cranial malignancies, intracranial malignancies are acceptable. However, most malignancies, there would be probably a no for the organ donation. Let's look at some of the pitfalls. During the apnea test, patient moves their arm at the elbow following imposition of painful stimulus to the nail bed. Is this patient brain dead or not? Is this brainstem diagnosis possible or not? Well, you would possibly say that it may represent a spinal reflex. The reason is the pressure was given at the nail bed. Again, I'm repeating, please do not give any peripheral pressure. Try and give it at the cranial nerve distribution. So that's the first wrong thing which many people do. and they say that the patient moved their hands or limbs, and that's not correct. It may be actually a spinal reflex which is there. Patient sits up during apnea test. In almost 150 to 170 brainstem declarations that I have done in the last 20 years, maybe more, I've stopped counting them now. I have had 2 patients who have done a complete Lazarus sign, where because while we were doing an apnea test, they almost sit up completely and they just fall back onto the bed. Is this consistent with brainstem death? Yes, it is consistent with brainstem death. It has happened to me twice. One of my things which I do is I always have the family with me when I'm doing the testing, and I always explain to the family about the spinal test. However, whenever both the times Lazarus has happened, I have stopped the testing, counseled the family again, gone back and completed the test next day again with family in presence, and organ donation was completed. The important message here is you should be clear about what you are doing and what are the problems. And communication, and trust of the family is the most important thing. Once you have the trust of the family that this person is doing absolutely right thing, and by keeping the family present at the bedside when you're performing the test, actually adds on a lot to the trust factor. The trust factor just improves by several folds. Day 2, 22-year-old female, unknown poisoning. These are all real cases. I have not put in any hypothetical cases. These are all real cases which have been referred to me. Brainstem testing done. Both apneas test done and patient was certified. There was no documentation of hypoxia, arrest, trauma, nothing. And cause of brainstem death was given as metabolic encephalopathy. Now that's a big no. This patient is a poisoning patient. You just wait. As Akshay said, 100 hours, 200 hours, 300 hours. I would be 100 times cautious declaring a patient who has poisoning with no history of cardiac arrest or CPR given or trauma or anything. I would actually go and do a CT angio to see if there is any brainstem flow or not. Not that I want to declare the patient brain dead using that criteria, but just for my satisfaction that yes, looks like the poison effect has gone away and the patient indeed does not have any brainstem death, brainstem circulation, and I may move with my brainstem death declaration. So metabolic can never be a cause for any death. Forget about brainstem death. Another 43-year-old guy, traumatic brain injury with some aspiration pneumonitis. PaO2 was 264 on 100% FiO2, which is a mild ARDS kind of a PaO2. We attempted apnea, it was desaturating. What we did was we used a Bain circuit to do a test, disconnect the patient from a ventilator. Instead of attaching a 4-liter cannula, we attach Bain circuit with 15 liters O2 and keep the valve half open. The anesthetist here would understand what I'm saying. Observe the bag movements, and we could complete the test eventually. This is a picture of a Bain circuit. This is again patient reported to Roto, Mumbai as a brainstem for declaration of distribution of organs. Here you can see the 2 ABGs, the one on the left and one on the right. The one on the left is showing a PA. The problem here is PCO2. PCO2 is 26.8 on the left one. The PCO2 on the right one is 51. The argument given was it is 20 above the baseline. Now again, I want to just remind everybody that those who have normal CO2, please try and bring the CO2 to the normal and then go for 60 and above or a 20 above criteria. Not for people who have been hyperventilated and the CO2 has been brought down to 26 and then you just raise it up to 50. It's not the correct test. So that's the argument. We need to again repeat this test by normalizing the CO2. Another patient, case declared brain dead. This is the ABG. In this ABG, you can see that the sodium here is 181, and post test is 183. Now, we have been given responsibility as doctors to declare a patient death, and it is our responsibility to make sure that the patient's parameters were physiologically as close to normal as possible before you started to proceed. So, an acceptable sodium after a brainstem death is below 160 for a patient to be going in for brainstem death. A perfect sodium would be below 150. So between 135 and 150 would be the sodium which I would like to achieve and start with the brainstem death testing. Why does the sodium go up? Because all of these patients go into diabetes insipidus and several liters of water is just lost in urine output. So it is actually reflecting a poor donor management. If the sodium goes to 183, it reflects a poor donor management. You need to replace them with free water and 5% dextrose and start them on vasopressin, so that the urine concentration starts happening. So that's another one. Another couple of slides just, and I will be done. This was a patient who had a generalized tonic-clonic seizures. Absolutely, again, as we have discussed, me and Akshay both, generalized tonic-clonic seizures are not consistent with brainstem. So you need to basically have a patient who is not having any convergence proven. This is another one, 28-year-old male. We have some difficulties at times. High-ranking civil services employee, hanging at home, brainstem diagnosed after the parents gave a consent, and after the consent, they refused donation. This is the big fear. That's fine, they refused donation. We basically had, did nothing. After around 3 or 4 days, the heart stopped, because the heart does stop after some time. It does not go on continuing for a long time. But what police did not understand is that we had declared the patient dead 2 days ago, and now why are you calling us for a postmortem 2 days later? These were some of the real life questions. Obviously, you need to just discuss this out. Ultimately, we gave it as a cardiac death and just signed up the death certificate on the day the heart stopped. And precious 24 hours of man hours were wasted in this whole process of trying to make people understand that what brainstem is. Just 1 day ago, I have had a full night where I've been awake, trying to make some people from the police station understand in Thane district that this is a brainstem death declaration which we have done, and they need to give an NOC for the patient because the patient was an MLC. And trust me, the police station wanted the entire family to be there, and it almost looked like the family was the criminal in the whole process. Ultimately, common sense prevailed. Everybody's intervention helped, and we could get it done. Just last 2 cases: 38-year-old patient with a grade 4 subarachnoid hemorrhage, potential donor, but spinal reflexes observed. First test was positive. Let's look at the video and tell me if this looks like a brainstem death or not. When you have these kind of movements, you have to be very, very worried. This is something which is not very clear. It's not a very good spinal reflex. So we stepped back and we did not proceed with the brainstem death declaration in this patient. While some people may say that it's just the peripheral reflexes, it's just happening after stimulation, but you have to be very clear. Yes, it's a catastrophic brain injury. Outcome is poor, but you cannot be declaring these patients dead. Last, CT angiogram of a brainstem death patient demonstrates some residual flow. Is the patient still brain dead? Well, we need to remember that up to 10% of the cases will have some flow, provided the preconditions are satisfied and there is no confounding problem regarding the clinical testing. The brainstem death can be actually declared using the functional criteria. Last one slide. Patient is registered for a brainstem declaration. The ventilator basically starts registering spontaneous breathing. Is this patient dead or not? Well, what happens is that the patient loses the tone of the body completely. So even the heartbeat or the aortic pulsations sometimes may trigger as if the diaphragm is actually triggering. And the ventilator sensor, if it is set at a very low sensitivity, it will start detecting that as a diaphragmatic movement, and the patient may be maintained on CPAP. So these are some of the problems which we need to understand, and they need to be corrected and understood, and basically the sensitivity needs to be changed, and you'll be able to do a brainstem death declaration. Thank you very much. I'll be happy to take questions if there are any.
So if there are any questions, please feel free to ask in the chat box. Meanwhile, there was one previous question which I'll take it up with you. You have already answered. Can brain dead children or adolescent be donors?
Yes, brainstem death can be declared from any age group, right from day 1 to whatever age of your life. However, the criteria for neonates, criteria for pediatrics are different. In neonates, between the 2 apnea tests, you may want to wait for several hours, sometimes up to 24 or 48 hours. Remember why? Because the frontanels are open. Unlike the adults, after 1 year, the frontanels are closed, so the brain becomes a closed compartment. In neonates, the frontanels are open, so the brain has got a lot of chance to swell up, and patient may not go across and have a brainstem dead because the brainstem may not actually cone down. So pediatric is very, very different. Neonate is even more difficult to basically decipher, and that's why I stayed away from it. But a pediatrician, and I have been involved in some of the pediatric ones where I've guided them how to do it. But ultimately, a pediatrician needs to be very clear. And I always feel that in pediatrics, please use the ancillary test to sort of at least convince yourself that you are right in the moving in the right direction. Though it may not be a part of the law, but I think ancillary testing in pediatrics is important. EEG is not a very good ancillary test. Only if you do a CT angio or a 4-vessel angio using BSA, they are the two which will give you very good understanding. Transcranial Doppler is very, very operator dependent. So unless you have an excellent person who does transcranial Doppler all the time, you should not be relying on transcranial Doppler. Again, transcranial Doppler will not look at the entire circulation. The most common circulation looked at is the middle cerebral artery, which may only represent a part of the cerebral circulation. The circle of Willis is not entirely covered in that.
Okay. And you said rightly that now there is a notification that you need to decouple the brainstem death and the concept of organ donation. So once again, for the benefit of the people who are attending, I want you to please say it that what a hospital or a team of ICU doctors who are not registered as NTORC or as transplant centers, what are they supposed to do when and if they think that the patient is possibly having a brainstem death? If there is any such patient in their hospital.
If there is any such patient in their hospital, sorry?
In their hospital.
In their hospital, if there is a patient in their hospital who is potentially brain dead, the scenarios would be that if they are an NTORC, they can go ahead with the declaration, inform the ZTCC, NOTO, ROTO. You can call me directly anytime. My number is available free on the net, or Archana madam, you can post my number.
Absolutely.
Any hospital, I keep getting calls right from all over the country for brainstem declaration. I am happy to help you out anytime. So no problem. ROTO, SOTO, ZTCC are extremely helpful and they will guide you rightly. If you are not a NTORC, then in Mumbai ZTCC, at least in Mumbai ZTCC, there is a rule. We have divided the city in 5 or 6 zones. So, for example, Mulund and Jupiter come in one zone. So, if there is anybody between Thane and Mulund, Bhandup area, nursing home which has a potential brain dead donor, the ZTCC decides to shift them either to Jupiter or to Fortis, which is alternating to in a way, so that we can then go ahead with the declaration. But the family needs to be basically told that you are shifting only for the purpose of organ donation there, because that's a very important thing. Usually nursing homes will not shift if the patient is just brain dead, but organ donation is not a possibility, which I appreciate. We struggle at times, so I appreciate that they must be really struggling with it. The concept of brainstem and donation is a very complex subject for many people. For us, it looks very simplified, but trust me, this is after several years that we are now doing it. The third thing which can happen is that you are a transplant center. So in that case, there is no problem. You can donate as well as you can go ahead with the transplantation. Madam, there is one question from Meenakshi Deshpande ji, who can officially give consent for doing.
Yeah, I just want to finish this question. So what my question was that when you say about a non-registered hospital, and if they see they suspect a brainstem death, they are not supposed to be declaring brainstem death in their hospital, and they have to contact somebody who is dealing with brainstem deaths, or they can contact ZTCC, or they can set that procedure in motion. Is that what is correct?
Correct, madam. They need to contact ZTCC, not the nearby hospital, or Roto Soto if they're out of Mumbai and there is. Say Maharashtra has ZTCC divided everywhere, so they just have the ZTCC contacted, and this will be set into motion very easy.
Yes, Patwardhan madam would like to say something, and then we can take question from Dr. Meenakshi. Patwardhan madam, would you like to say something?
Good morning, Dr. Rahul Pandit, and thank you very much. You are one of the great star players in this entire program. Sir, as you know, critical care in all the public hospitals, they don't have a critical care unit at all. And there is nothing specially dedicated to critical care of, forget brainstem death patients, of the patients who require critical care for other reasons. And sir, what would you say about it? Like, how can we overcome this? This is one of my major concerns as of now.
Madam, मराठीत जर बोललो की फार मोठी शोकांतिका आहे. It is actually a very sad thing. that our premium medical colleges like KEM, SIAN, NIR, JJ do not have an intensive care training program. It is for the IMA, the government. I have been pushing very hard to the government of Maharashtra as well as at the all India level as well. But it requires more than just one person. I think IMA is the right platform. Archana Madam, Pate sir, I would really like IMA to take this at a national level, that every medical college should have a dedicated intensive care department led by an intensivist. Now, again, I'm not trying to go back to COVID, but COVID gave us two very important messages. We require intensivists and we require ID specialists. And how are we going to make it? Now, in the current situation, what Patwardhan Madam is bringing, I think, Madam, Tumala, you will have to basically nominate a champion within the department of either medicine or anesthesia. Most likely it will be an anesthesia-led process because it is easier, because they can do the apnea test very easily. And then you will have to have a process setting right from the dean of KEM hospital or SIAM hospital, wherever the donation is happening, that all of these people who are required to come across and donate, do the donation successful, the certification successful, come very easily. And I would like to exclude the neurologists and neurosurgeons from this process because they are very difficult to find time. So it can be two anesthetists, one anesthetist, one physician. Let's just do it at our level. Neurologists and neurosurgeons can be consulted if there is a problem. If the primary patient is under neurologist and neurosurgeon, they will be involved. So it should not be a problem. But otherwise, let's just have intensivists in form of either physician or anesthetist in medical colleges, and let's just go ahead with the procedure. If we start doing a neuro call, then there are number of tests, number of problems which come across. It's a clinical declaration. As per the law, actually an MBBS person with sufficient experience can also do it. The law doesn't allow that. The law wants either a specialist or a neurologist or an intensivist to do it. But if you look at what we are doing, it's not very difficult. Just the apnea test needs to be monitored by somebody who understands the ventilator, for which anesthetists are more than capable. So my suggestion would be to involve physicians and anesthetists, madam, leave the neurologists, neurosurgeons for expert opinion only, so that we can quickly complete the test.
My suggestion on this would be that, as I said, that we do have a huge reach out. I would have a very simple and a humble suggestion on this. I do not know to what extent is this feasible, that why can not there be training program for the physicians and anesthetists, to make them into, people who are good enough to certify brain death in hospitals. So if you have a team of doctors who are registered with THS, not only from the NTORCs or from the transplant centers, but if we can have training programs where certification training programs for the intensivist physicians, anesthesiologists, wherein they can come on board and you can have an entire list from all the areas across Maharashtra. Probably they can go to the hospitals which are having such kind of patients who are suspected brain death patients, and they can primarily say that yes, this looks like it and we should be going forward. Because believe me, when we say in smaller hospitals, for a doctor to talk to a relative and say that your patient looks to be brain death and we should consider organ donation, in itself is a very, very, very big challenge, and it just does not and cannot happen randomly. So it would be my suggestion, and I do not know how far it is possible to be taken up by the government. So Patwardhan Madam, over to you. Wanted to say something.
See, training programs for all the intensivists in public hospitals is being done by Dr. Rahul Pandit and the entire critical care doctors in Mumbai. They are very kind to spare their time, come and do it. Everything is being done, but the basic problem is apathy, I feel, and that is very difficult to get over. As you said, team of doctors which are attached to the transplant center of the nearby transplant center, like if an NTORC calls them, they are allowed to go, but to do it across hospitals, I don't know whether it would be permitted, because a person is registered to a certain hospital, whether it can be. So maybe we take it up with the government, we can find out a solution. Sir, I thank you again, and please do work on this, as you are a part of the task force, and I look up to you to help me in this situation, which we are deeply into. And thank you, Archana, for allowing me. Yeah.
So last
Well
question,
said.
Dr. Meenakshi Deshpande has asked, which of the patient's relatives can officially give consent for brainstem death organ transplant? We will quickly take this up and move on to the next session.
So it is also a part of the act. Wife, parents, brothers, sisters, grandparents. This is how basically it goes. If none of them are there, then you need to go to the second level. But usually between these is what, so spouse is the first of thing. For children, it is the parents who is the first line of contact.
And thank you so much, Dr. Pandit. It is always a pleasure to listen to you. And with this, we are very happy to present to you Certificate of Appreciation for taking this excellent session on brain death certification and common pitfalls today at DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. So thank you so very much for being here today with us. And moving on
Thank
to
you,
the
madam.
next session, heart failure may occur due to a variety of reasons: cardiomyopathy, coronary artery disease, arrhythmias, congenital heart disease, valvular heart disease. The reasons are many. Though there are many treatment options available for heart failure, end-stage heart failure, where no other treatment options are working, heart transplant may offer the only chance of survival. To talk on heart transplant, the ultimate savior for failing heart, we have Dr. Satish Savli. Please allow me to put forward his PPT. I'll just share the screen. Yes. So Dr. Satish Savli is MCH from KM Hospital, Cardiac Surgery Fellowship he has done from Auckland City Hospital, New Zealand, Cardiac Surgery Fellowship from Harvard University, Massachusetts General Hospital, Boston, USA. Before joining Fortis Mulund, he was working with Apollo Chennai and Seven Hills. Currently, he is with Fortis Hospital Mulund since 2016. He has done total 114 transplants at Fortis Mulund. He is experienced in off-pump CABG, valve replacement, aortic surgery, and heart transplantation. Hearty welcome to you, Dr. Javli, on DAAN Fest, and may I please request you to take over the session.
Thank you very much, Dr. Archana Pate. Thanks for the privilege given by the IMA Maharashtra Organ Donation Committee. And good morning to all the dignitaries and participants. I'm sharing my screen. Can you hear me properly?
Yes, sir. You're audible.
So I'm going to talk about heart transplant. So heart transplant is required in the patients with the terminal heart disease. The causes are many. Just starting the slideshow. Yeah. So I said that it can be because of congenital heart disease.
If you can just make it full screen, that would be more visible clearly.
Can you see it now?
Absolutely.
Okay. So causes are many. There may be because of ischemic heart disease, congenital heart disease, dilated cardiomyopathy because of various reasons, because of toxins, medicines, or viral myocarditis. The symptoms are mainly fatigue, that is on patient get tired over a period of time. The activity decreases. Sometimes they get cough, mainly in the supine position, which we also say as paroxysmal nocturnal dyspnea, which is seen very commonly. Edema feed, this is because of the right heart failure and there is a lot of fluid accumulated as the heart can't pump properly, and patient gets shortness of breath, mainly initially on walking, but sometimes later on even at the rest. So the chronic congestive heart failure goes through different stages. So initially it's a normal person will have no symptoms and they can do normal exercise with normal LV function. This first stage is usually asymptomatic, but there is a abnormal LV function, and the symptoms comes when there is on exercise only, that is in compensated cardiac failure. In this, there are no symptoms, but on exercise, the exercise tolerance is decreases over a period of time. From that stage, the patient goes into the decompensated heart failure where there are symptoms, and with exercise, the symptoms actually goes on increasing. On echo, the LV function is abnormal. And the last stage is refractory heart failure where the symptoms are not even controlled by the treatment. So in the first stage, the causes are usually hypertension, coronary artery disease or diabetes, or exposure to cardiotoxins, or the family history of cardiomyopathy, where there is a structural heart disease, but the patients are asymptomatic. and they move on to the stage B, where there are symptoms which are coming with the exercise or exertion. The treatment to them is initial phases is preventive treatments like treatment of hypertension, smoking cessation, treat the lipid disorder, encourage regular exercises, and AC inhibitors. All stage 1 will, in stage B, there will be stage A treatment plus AC inhibitors and beta blocker symptoms. We move on to the next stage, which is heart failure symptoms, where there are known structural heart disease. The patient gets shortness of breath, fatigue, and reduce exercise tolerance, and which moves on to the marked symptoms in spite of maximal medical therapy. The treatment of all these stages is introduction of diuretics along with AC inhibitor, beta blocker, and digitalis, and sodium restriction. Even when this stage fails in say C, the patient goes into the refractory heart failure, where there is something more is required in terms of continuous IV inotropic infusion of milrinone for treatment, as well as waiting for further treatment, or mechanical assist device and heart transplantation. So normal NIH class 4 is divided into 6 levels for the purpose of deciding them into the which stages of heart failure. Level 6 is exercise limited. They are like walking wounded. They are around months before they come to the hospital. The level 5 is exertional tolerant. They can't do the normal exercise, but on exertion they have become housebound. So they have weeks and months for the actual support system requiring. Level 4 is recurrent advanced heart failure. Those are the patients which are known as frequent flyers, which have few weeks to few months. They come to the hospital many times with the heart failure, get treated and go home. Level 3 is the patients which are admitted but are holding on with the ionotropes, infusions like noradrenaline or milrinone. They are stable but still dependent. So they have few weeks or something till they get the heart transplantation or mechanically circulatory support. Level 2 are the one who are on progressive decline. They, in spite of treatment, they slide fast. They have only days or weeks to get to the final treatment. And level 1 is in cardiogenic shock, where they crash and burn. They come with the they are in the ICU. They are not holding on to their hemodynamic status. They have developed the liver enzymes going up, or the edema which is increasing, and on a ventilator or mechanical circulatory supports. They are the one who requires like urgent registration for the heart transplantation and proceed for the procedure. So refractory heart failure therapy is all stages. What is the treatment for the A, B, and C, all of them. With addition to that, may require mechanical assist devices or require heart transplantation. Many of these patients are the continuous inotropic supports for either waiting for the transplantation or for the palliation. And the last is the hospice care, where we are thinking of not doing anything. So why and which patients should be treated? So there was a study in 1993 that they have studied around 382 patients with the class 3 and class 4 NOIHA. The LV size was measured by the end diastolic diameter compared to the body surface area. The LV size is one of the main predictor of the sudden cardiac death. It is also related to the arrhythmias, because the heart is so enlarged, they are more common for arrhythmia. And these are the patients in whom pacing or the AICD, not pacing, the AICD is recommended. The LV size more than 4 centimeter per meter square had a 2-year survival of only 49%, as compared to 75% those who have a size less than 4 centimeter. So echo actually can give you a good idea of the patients which will require heart transplantation or which won't. And this is independent of the diseases or the EF, what you notice in the things. In one other thing is, in these patients, valvular heart disease should be ruled out, because in presence of valvular heart disease, the 4 centimeter criteria is not valid. So these are the patients which requires actual heart transplantation, are the cardiomyopathies, which is congenital idiopathic, viral or ischemic, or drug induced because of chemotherapeutic agents. These are the patients in refractory cardiogenic shock. Recurrent arrhythmia is one of the reason for transplantation in spite of having adequate LV function. And those which are in end stage heart failure, which requiring inotropic supports or admitted into the hospital. So what we are thinking in terms of surgical approaches to the heart failure. So there are many options which were tried but failed, some before the heart transplantation or along with the heart transplantation to avoid the heart transplantation. So one of them is transmyocardial laser revascularization, end-to-end mitral repairs. These are, for just to mention, the cardiomyoplasty. These were tried but failed. There is core cap cardiac support device, mesh or intracavitary rod into the LV, partial left ventriculotomy in those patients which have a large left ventricle. Stem cell therapy, the use is questionable still, but they are making rapid strides in the research. So the only two therapies, that is mechanical circulatory support devices like ECMO and LVAD, can be helpful in the failing heart at that stage. And the last and the best is the heart transplantation. So the recommendation or evaluation of heart transplantation is recommended in selected patient with the following: who have severe heart failure, refractory angina, which is not responding to the angioplasty, surgery, and medications, and ventricular arrhythmia that cannot be controlled despite drug, device, and alternative surgical therapy. The patient awaiting heart transplantation who have become refractory to all means of medical circulatory support should be considered for the medical support device as a bridge to transplant. So these are the patients who are basically waiting for the transplant, but because of scarcity of the organs, patient are still not fit immediately for the transplant, needs mechanical circulatory support device. The decision from bridge to transplant or bridge to destination depends on the patient condition. Permanent mechanical device, that is means those who are not candidates for the heart transplantation. So permanent mechanical assistant using an implantable assist device, the newer LVADs, may be considered in highly selected patient with severe heart failure, refractory to conventional therapy, who are not candidate for heart transplantation, particularly those who cannot be weaned from the inotropic support at an experienced heart failure center. So these are the components of the mechanical circulatory support. Mechanical circulatory support means that the blood from the body is taken out and it is pumped inside the aorta again with the pump which is outside the body. So these are the components: pump, motor, and the console. And it can be, this is the CentriMac device, which can be used as a ECMO or left ventricular assist device. The difference between that is in ECMO, the oxygenator is added and the lung function is also supported. This is the HeartMate 2, the LVAD device, which is a surgically implantable continuous flow device, where the device is connected intrathoracic to the left ventricular apex and pushes the blood into the aorta, and it is controlled by the controller which is outside the body, connected with the percutaneous lead to the device. This is percutaneous drive line. It is electrically powered, which has battery on both the side. Patient has to carry it. It is on fixed speed operating mode. Patient can live with this, doing their normal activity, go for daily life and all those things. Only thing, it is still considered inferior to the heart transplantation. So it is used in the patient who are waiting for the transplant, and the patients which are not fit for heart transplant, in them it is used as a destination therapy. So one thing is bridge to transplant, where the risk of imminent death from the non-reversible left ventricle failure, and those who are candidates for the transplantation, the LVAD can be used. A destination therapy in patients which are in class 3 or B and or even on optimal medical therapy for almost for 1.5 months in the last 60 days, and they are not candidates for the cardiac transplantation. In them, the permanent LVAD can be used. In our system, we are using temporary LVAD as a measure to support the heart to, if they are not tolerating the medical management and they are waiting for the heart transplantation. So this is the heart transplantation, the surgical thing. We do excise the heart and connect the cadaver's donor heart to the left atria, then IVC, SVC, aorta, and the pulmonary artery. The main thing in heart transplantation is the cold ischemia time, which is only 4 hours. So we have to retrieve the heart, transportation and the anastomosis or the operation should take place within 4 hours for a better outcome. So in Fortis Hospital, Mumbai, from August 15, we have done around 114 heart and lung transplantation with around 103 hearts. And we have a quite good results in heart transplantation. So we need detailed evaluation, pre-operative preparation of the recipient, the neo-marginalization of the donors, because we have a bit lesser donors available for the transplantation. The post-op immunosuppression is a major role in the outcome of the patient. A surgical treatment of the stage 4 heart failure in terms of heart transplantation has a good results and excellent prognosis. So from our experience, we have lessons that is early transplantation have better results. The ECMO or LVAD, temporary LVAD for the bad right ventricle is life-saving. If there is no urine output pre-operatively, which is usually coincides with the bad prognosis, post-operative immunosuppression, biopsy to prevent the rejection, and close follow-up to detect rejection early has long-term benefits. Thank you very much.
Thank you for the excellent session, Dr. Zawri. If there are any questions, please either put it up in the chat box or you can raise your hand and I'll invite you to ask a question. Dr. Zawri, if you can just close the share screen.
Yeah.
If there are any questions, please do ask. I think we see many heart failure patients. It is definitely imperative. There are many times when we see them being treated at local levels. You know, they are not really sent further, not only to alleviate the symptoms, but definitely to consider if anything further than what is being done conventionally for the refractive heart failure, something needs to be done. It is very important that such patients are referred further and you know, they are evaluated very well. They are given optimal treatment, and if there is anything which is not possible for the refractory heart failure, the patient is given a chance to consider heart transplant and they get onto the waiting list. So thank you, Dr. Zawri, for that wonderfully elaborate session. And if there are no questions, should we move forward?
Thank you very much.
We sincerely thank Fortis Hospital Mulund for their educational association with this session, and with this it gives me great pleasure to present with a certificate of appreciation to Dr. Zawri for taking this excellent session on heart transplant, the ultimate savior for failing heart, during organ donation and transplant symposium DAAN Fest organized by IMA Maharashtra State Organ Donation Committee today on 11 September 22. So thank you very much, Dr. Zawri, for being here and sharing your expertise with the delegates today. Our next speaker, who is Dr. Gaurav Gupta, who was going to speak on all about liver transplant. He is busy in OT right now. So we have requested Dr. Ravindra Nikalji, and he has gracefully accepted to take the session after this particular session of Dr. Zawri. So we move on to our next session. Patients with CRF usually progress through different stages before they reach end-stage renal disease and require special medical, social, and psychological care and support during the pre-ESRD and following renal replacement therapy. Early referral of patients with CRF has the advantage of receiving adequate management and regular follow-up with significant reduction in cardiovascular morbidity and mortality, counseling, psychological preparation, early creation of dialysis access if needed, and transplantation if needed. We have with us Dr. Ravindra Nikalji to enlighten us on from CRF to kidney transplant. Please allow me to share screen so that I can. Yes. So Dr. Nikalji is MBBS, MD, DM nephrology. He is a fellow in nephrology, dialysis and transplant at prestigious University of Toronto, Canada. He stood second in DM nephro exam held by Mumbai University in 2007. He is currently chief consultant nephrologist and transplant physician at Apollo Hospital, Navi Mumbai, having performed maximum number of kidney transplants in city of Navi Mumbai. He has published several papers in national and international journals. He is member of American and International Society of Nephrology. His main areas of interest are hypertension, glomerulonephritis, CKD, and dialysis. Warm welcome to you, Dr. Nikalji, and I request you to kindly take over the session.
Yeah, thank you so much, Dr. Archana, for such a kind introduction, and I'm so happy to be able to speak to all of you. Ma'am, my slides are visible?
Not yet, sir. Not yet, sir. So you made co-host, you should be able to share the screen. Sir, I've called you. I'll just guide you through.
Yeah, ma'am, actually, I know this. Just a minute. Now?
Yes, it is visible, sir. If you can just make it full screen.
Yeah, let's go ahead. So let me start. So the ideal, the heading of this topic should have been from failure to survival. So, the journey of chronic kidney disease, which progresses to ultimate end-stage renal failure and then requiring organ replacement treatment in the form of dialysis or transplant. So, this is a very, very long journey, and we see these patients along the, the continued spectrum. And to tell you honestly, there's really CKD has the populations of CKD patients has exploded in the last decade or so in India. And this is because the ever-increasing incidence of diabetes, hypertension, and patients are living longer with diabetes and hypertension. So they live longer to face the complications like congestive heart failure or chronic kidney disease. In no other chronic disease, this dictum that prevention is better than cure applies, better than this particular condition. And really, because the treatment options are limited, treatment options are not very easy, and treatment options are very costly also. Not everybody can afford. So it's always better to prevent this chronic kidney disease. Dialysis is not the perfect treatment for this kind of chronic kidney disease. It's an intermittent form of treatment, and at the most tries to control the metabolic and uremic manifestations. Kidney transplant is available to only select few. I'll show you how, and we'll see how the transplant fares for dialysis. So the only advantage for patients with chronic kidney disease is they have something to live with till they undergo transplants, which is not the case with other organ failures like patients with congestive heart failure or even end-stage liver disease, end-stage lung disease. These patients unfortunately have a very limited options, and they need to get organ transplant very quickly. But fortunately, at least for our patients who are suffering from end-stage chronic kidney disease, end-stage renal disease, they can live alive well on regular dialysis 2 or 3 times a week, and they can look forward to getting kidney transplant and lead a more healthier and fruitful life. So chronic kidney disease is nothing but irreversible and progressive loss of kidney function, which develops over a period of months to years, and it leads to loss of excretory, metabolic, and synthetic functions of the kidney. As I said previously, the #1 cause in our country as all over the world remains diabetes and hypertension. And these two together really contribute to continuous loss of kidney function. And the other common conditions for the chronic kidney disease being polycystic kidney disease, congenital diseases, and glomerular diseases, especially to mention IgA nephropathy, which is very common in Southeast Asian population and India. The issues with polycystic kidney disease, congenital disease, and glomerular diseases is that it affects the young population. So we need to be very, very careful because diabetes and hypertension usually will have an CKD after 10 or 15 years of diabetes and hypertension. So these patients present late. Unfortunately, when you look at the why the kidney diseases are diagnosed late in their course is because commonly there are no symptoms initially. Our first few symptoms are very, very vague and non-specific, like poor appetite, fatigue, nausea, vomiting, or itching. which are really not given enough attention. Anemia, which is so common, and very few of us will try and look at the kidney function, as a cause of chronic anemia. Swelling of face or legs, high blood pressure, breathing difficulty, which is due to fluid overload, usually happens very late when the GFR is usually less than 20 or 30 ml per minute. And some elderly patients may present with obstructive symptoms like polyuria, nocturia, etc. So since most of these patients have very few limited treatment options like either dialysis or kidney transplant, so we must do everything to prevent chronic kidney disease. So it is important to screen high-risk population like patients who are already suffering from diabetes, hypertension, who have a history of ischemic heart disease, congestive heart failure, who are or obese. So these are the risk factors, and these patients should be given really a good yearly or 6-monthly screening to assess for their kidney function. Patients who have a family history of kidney disease need additional attention. And patients who are known to have a structural kidney disease like kidney stones, single kidney, or any congenital malformations, recurrent kidney stones, they need to be given special attention to screen for any loss of kidney functions. It is so easy to screen for or detect chronic kidney disease early in their course. Simple test: serum creatinine, GFR, serum cystatin, urine routine or urine albumin creatinine ratio, and sonography. That's all we need. So it is so easily available to all of us, but still it is underutilized, and we still see patients quite late in the course of chronic kidney disease. Most of the time they are referred to us as stage 5, and it becomes very difficult to convince them that there is no option except dialysis or kidney transplant. So when you start looking at the serum creatinine, we have to understand first it is not the creatinine alone. I mean, there are a lot of fallacies with this test, though it is very commonly available and it is done all across in each and every lab. But we have to understand that we have to even calculate the GFR, because sometimes the normal serum creatinine can fool you, and seemingly normal creatinine may not mean the normal GFR. So at elderly, so if you look at a creatinine of 1.4, which would probably be a normal in some labs, in a 66-year-old man would have GFR of around 57 ml per minute, which is a stage 3 chronic kidney disease. So it is important to measure GFR, not only creatinine. And if you're not very convinced about the creatinine values, we have a serum cystatin C, which gives a better predictive ability to detect earlier loss of GFR. Not only GFR or creatinine, you should also look at the urine. You should please, especially diabetic patients who are, a lot of us are managing this diabetic patients over a period of years. You must look at their urine, and if there is any protein in the urine, you must calculate urine albumin creatinine ratio, because this is an opportunity to treat, diagnose diabetic nephropathy at an earlier stage and prevent chronic kidney disease or end-stage renal disease. So a person who has a normal GFR, even if they have proteinuria or hematuria, will be classified as having a chronic kidney disease. And all of us know GFR less than 60 ml per minute, which persists for more than 3 months, would classify as a chronic kidney disease. What are the interventions available to slow the progression of chronic kidney disease? Well, it's simple. It again boils down to the etiological factors. So diabetes, blood pressure, ACE inhibitors or ARB to reduce the proteinuria, and looking at the cardiovascular disease. These patients have an extremely high cardiovascular disease burden, and most of these patients who die of cardiovascular death even before they reach the final stage of stage 5. So extremely high cardiovascular mobility. So they should be given proper secondary prophylaxis to prevent cardiovascular disease, like ecosprints and aggressive strategies to reduce the lipids. So ultimately, once you have the GFR comes to less than 30 or less than 25 ml per minute, you should start counseling these patients for renal replacement therapy. And the only options that we have currently available, as I said previously, it's either dialysis or a transplant. It's not available to everybody, especially in remote areas, villages. It's very difficult to get access to dialysis or a transplant. So it's best to treat, screen, and prevent chronic kidney disease wherever feasible, especially in high-risk population. So dialysis, I'm sure all of us have seen some of these patients at some point or other, either in OPD or admitted to hospitals. This is really a chronic treatment. So it's basically spending a life with machine, artificial means to remove toxins and waste products and excessive water from your body with the help of a machine. It can never match normal kidneys function or normal filtration, because it's only done intermittently 2 or 3 times a week. and especially the synthetic functions like production of erythropoietin or production of vitamin D are never replaced. And these patients always need additional medicines to control the blood pressure, supplements like calcium, vitamin D, and erythropoietins. However, as I said earlier, if these patients are dialyzed well and if we achieve adequate clearance of their uremic toxins, these patients can really lead a good quality of life, even the young ones, and they can look forward to receiving transplants as and when it's possible. Two common forms of dialysis, hemodialysis and a peritoneal dialysis. All of us have hemodialysis is available like very commonly in city of Mumbai and Navi Mumbai, but as you go to the remotest area, it becomes very difficult to have an access to these chronic treatments. So it's kind of a intermittent, regular treatment, bit painful. You need placing of needles into the arteries and veins, basically the dilated veins into artery veins fistula, and it is done 3 times a week. And as I said, it is repeated intermittently 3 times a week. There is an ideal frequency. Peritoneal dialysis, another way to dialyze or the treat chronic kidney disease, end-stage kidney disease, is the peritoneal dialysis. This is a kind of a home dialysis treatment where we use the patient's own peritoneal membrane, which lines the abdominal cavity and internal organs as the filtering surface. We leave the peritoneal dialysis fluid inside the peritoneal cavity via peritoneal dialysis tube and drain it after a few hours. Peritoneal membrane separates the blood in the capillaries, which is high in urea, creatinine, potassium, etc. It separates the blood in the peritoneum from the dialysis fluid, and there is along the concentration gradient, the dialysis keeps happening. And the excessive, the waste products, excess sodium and excessive water which is removed is passed into the peritoneal fluid, which is drained out at the end of 6 to 8 hours. And again, this is a continuous or continuous treatment. So some patients are better suited for chronic peritoneal dialysis, especially it suits kids well. It allows for a proper growth. Elderly patients who are immobile, patients with congestive heart failure who cannot tolerate hemodialysis, patients who have baseline low blood pressures, and patients who have a very difficult vascular access and the IV fistula is not possible. So this remains the kind of available options to patients with suffering from end-stage renal disease. And as I said previously, it is at least these patients can lead a reasonably good quality of life if they do proper dialysis, either hemodialysis or a peritoneal dialysis. And since the transplant is not possible for each and everybody. Now, coming back to the transplant, so there's no doubt that transplantation offers the best survival and best quality of life for everybody, all demographic groups with ESRD. Transplantation is the most cost-effective in the long run. A lot of people think about transplant as, it's a very expensive affair, but that's not the case. If you look at the cost of continued dialysis over a period of years versus the transplant cost, transplantation is quite cost-effective in the longer run. There's a strong evidence that transplant is most successful if it's started before the onset of long-term dialysis. So if you start dialysis, if you do kidney transplant before, which is a preemptive kidney transplant before patients even start dialysis, the outcomes are much better. And all over the world, only 2.5% of patients suffering from stage 5 chronic kidney disease will undergo transplant as the first choice of renal replacement therapy. Graph looking at the survival of patients on various forms of renal replacement treatment, and it's quite obvious that if you look at the top, the patients with transplants have best survival advantage compared to the patients on dialysis. And here actually the peritoneal dialysis fares better than the hemodialysis. That is because the better clearance of the uremic toxins and better clearance over the volume overload. But transplant is #1 choice for patients suffering from end-stage renal disease. As I mentioned previously, most of these patients have an excessively high cardiovascular disease burden, and most of the dialysis patients would succumb to some or other form of cardiovascular disease, be it ischemic heart disease, congestive heart failure, sudden cardiac deaths, arrhythmias, and transplantation even reduces cardiovascular disease burden, and it allows them to have a good productive life. So why there are so few transplants happening? And that's obviously because of the mismatch between the demand and the supply. So there are very few donors available. Cost, in the long run, it may be cost effective, but in the short run, a lot of people are not able to afford the cost. There is a lot of, there's too much of information available. And of course, it brings in a lot of misinformation. about the process of organ donation, retrieval from the cadavers, and process of transplant. And my previous speakers, especially Dr. Rahul Pandit, has already told us about few cases how this whole thing spans out. And sometimes it really leaves a bad taste, and we also in our hospital had to cancel out few cadaver transplants because of the misinformation by some relatives. This is the organ crisis in India. Per year we need around 1,75,000 organs. Only 5,000 donors are available. So 5,000 donors mean 10,000 kidneys. The same applies to other organs like heart, liver, and cornea. So there is tremendous mismatch between the demand and supply. Kidney transplant, now of all the patients suffering from ESRD, kidney transplant remains the best option for patients who are in the pediatric age group, because it not only allows for better survival and better quality of life, these patients can grow well and they can really reach their growth potential and they develop well. It also adds, it can avoid long-term dialysis related complications. So all pediatric patients who are experiencing progressive growth failure, developmental delay, or progressive renal osteodystrophy, they should undergo kidney transplant ASAP rather than wasting time on dialysis. Now, kidney transplant so commonly done all across in city of Navi Mumbai. Most of the major hospitals and most of our public hospitals are doing an excellent job. First kidney transplant done in 1954 at Massachusetts General Hospital. This was done between the two haploidentical siblings, and really without any immunosuppression, patient did extremely well, and the recipient died 8 years after transplant. So it's, I mean, that's quite significant considering the lack of good immunosuppressive medicines at that point of time. This is the process of kidney transplant, which typically happens. If you look, patients will get a kidney either from the living donor, or if they are lucky, they can get it from the deceased donor organ pool. Patient gets a kidney transplant, kidney starts functioning, the dialysis stops, and usually 7 to 8 days patients are able to return getting discharged from the hospital. These patients need to start on immunosuppressive medications right at the beginning, right at the time of surgery, which is called induction immunosuppression, and they need to continue regular medicines, which is called a maintenance immunosuppression. This is to prevent organ rejection. Usually, patient is able to return to work after 4 to 6 weeks. Usually, by the end of 3 months, the acute rejections episodes are less common, and the risk for develop acute rejections reduces after 3 months. And after 1 year or so, the risk of rejection progressively goes down. The dosage of the immunosuppressive medications come down, and these patients are really able to return to an active life. And this is how the journey goes. So patients are counseled that they need a kidney transplant. Patients are started on dialysis. Some patients may get kidney transplant even without a dialysis. There's a lot of anxiety. There is a lot of counseling which is required for the patients, for the family of the patients. Sometimes patients are lucky, they get a living donor, they have a donor available in the family, and otherwise they have to wait for a very long time on the donor waiting list to get a kidney transplant. There is a lot of fear and misinformation about the surgery complication. There's a fear about the living donor surgery, so the donors need to be counseling. There's a fear about the life after transplant, continued need for medications, wound care, diet, return to work, warning signs of rejection. So there are so many things that these patients need counseling about. So we all know that these organ transplant for any organ are governed by certain compatibility. So we need a blood group compatibility, we need HLA compatibility. So the same rules which are applicable to blood transfusion apply to these patients. So we need the O is a universal donor, AB is a universal recipient. However, we have done a lot of kidney transplant across the blood group, which is called ABO incompatible kidney transplant. So whenever we don't have a blood group compatible donor, and we can offer them kidney transplants against the blood group barriers. HLA compatibility. So the most important molecules are HLA-A, HLA-B, and HLA-DR. And as we know, as the HLA mismatch increases, or the HLA incompatibility increases, the transplant outcomes may go down. So this is the survival of the kidney, transplant kidney based on the HLA mismatch. So as the zero mismatch, which is a haploidentical siblings, you may not even need immunosuppression. And as the number of mismatches increases, the graft life or the outcomes may suffer. This is how the transplanted kidney looks. It's a new kidney. It's a third kidney. The old kidneys usually are retained. This kidney is placed extraperitoneally in the iliac fossa, and there is artery to artery, vein to vein anastomosis, and there is a ureter is anastomosis to the bladder. This is the current trends in the donor nephrectomy. These are now either done laparoscopically or robotically, and donors are usually returned to work like very quickly. So usually they are discharged on third or fourth day, and they are returned to work at the end of 3 to 4 weeks. This is how it was done previously, and this is what it is being done now. So there has been a lot of refinement, a lot of innovations in the surgical techniques which have improved the quality and the outcomes. So advantages of living donation is, of course, I mean, it is the graft survival is better compared to the deceased donors. Half-life of the kidney is longer. There's immediate kidney function, and there's no need for post-operative dialysis, and there's a shorter waiting time, and you can even undergo preemptive kidney transplant. However, disadvantages to the living donor is the GFR reduces. These patients regain some GFR, but immediately after removal of one kidney, the GFR falls to 75% of the basic. These patients are exposed to increased risk of developing blood pressure or cardiovascular risk later in their life, and these donors need to be aggressively monitored. Now coming to the medicine. So we have to understand that all these organ transplants work only if they are given immunosuppressive medications. Except HLA identical siblings, most of the other kidney transplants who need transplant medications or immunosuppressive medications to prevent rejection and to continue these allografts to function in the recipient's body. And these are medications which are required for lifelong, and it's not one. I mean, usually you need a combination of 3 medicines, which is usually one of them is a calcineurin inhibitor, either tacrolimus or cyclosporin. Second is antimetabolite, which is either mycophenolate or azoran. Third is steroids. So steroid remains common. These medications are taken throughout, and we also need some induction immunosuppression at around the time of surgery to prevent acute rejection. This is how the immunosuppressive armamentarium has evolved over a period of time. In the initial periods of kidney organ transplantation days, we had very few medicines, only azathioprine and prednisolone, radiation and anti-lymphocyte antibodies. And there were excessive deaths, excessive risk of graft loss. And as we have more and more effective immunosuppressive medications, the graft survival is increased. So is the complications and side effects of the immunosuppressive medications. These are phases of immunosuppression for any organ transplant, be it heart, liver, or kidney. So we need an induction treatment, which is at the time of transplant. This is to prevent acute rejection. Then we need a maintenance treatment with usually with 3 drugs in kidney to prevent ongoing rejection. And we need intermittent treatment if the patient develops rejection. It is very difficult to maintain a balance between the how much is required to continue to maintain the graft function, and this is given when you have these medications for a very long period of time. You are exposed to infections, severe viral infections like CMV, BKV, tuberculosis, malignancies, especially lymphoproliferative malignancies are very common in the long run, and drug-related toxicities. So we are always now, once we have reached crossed the 1 year mark, we are always looking at minimization of these immunosuppressive medications. So because these medications come with a lot of side effects, nephrotoxicity of cyclosporin or tacrolimus, long-term malignancy potentials, hypertension, type new onset diabetes, bone disease, hyperlipidemia, cosmetic problems, and long-term side effects of steroids. So once the patients are past 1 year mark and kidney function is stable, we aggressively try to reduce the number of medications that these patients are receiving. So there's always a balance between the rejection and to prevent infections or complications and the side effects of the medications. And these are the number of different medications that we have available for kidney transplant or any organ transplant recipients. And with this I'll end my talk. And thank you so much.
Thank you so much, Dr. Nikalji, for that elaborate session. It was, I mean, it gave an entire encompassing picture of what this chronic renal failure patients go through, and what are the chances of survival post-transplant, what are the things that needed to be done after the transplant. My question to you is that you mentioned something about long-term use of ranitidine, famotidine, giving, an increase in the when we do a creatinine estimation. So my question to you is that we are very clear on use of NSAIDs, that they are very, very harmful to the kidneys, but nothing much is said about the long-term use of PPIs. I mean, what is their effect on the kidneys? And second thing is we see a lot of trend in use of protein supplements by the people who are going to the gym, and excessive use of protein supplements. Can you just say something about the effect of all these things on the
ma'am,
kidneys?
this cimetidine, famotidine I mentioned only because it inhibits the tubular secretion of the creatinine, and it may kind of artificially increase the serum creatinine. So whenever we find such patients, and there is, we cannot explain the rise in creatinine, and these patients do not have any risk factors. Many times we've seen that patients have taken either Septran, which is trimethoprim with sulfamethoxazole, or your drugs like these, which inhibit the tubular secretion of creatinine, and creatinine may go up. And once you withdraw the drug, creatinine remains to normal. Okay. So this is basically a reversible effect on the tubular secretions. About the PPIs, now there is enough data, long-term data, to suggest that when these patients are, when these medications are taken chronically, they cause chronic interstitial disease. And now it comes with a kind of a black box warning that patients who are suffering from chronic kidney disease should avoid from continued use of PPIs. And patients who are normal kidney function, but they are taking PPIs on a longer term basis for whatever, maybe the reason, GIRD or this ulcers, patients should be monitored with their kidney function. It's not that everybody develops, but it can contribute to chronic kidney disease in certain amount of patients. And it's mainly interstitial disease. Then about the protein supplements, yes, this is a very disturbing trend that we notice, and it doesn't happen to everybody. But see, I mean, there is something called, the nephron mass. All of us are born with certain amount of nephron numbers and nephron mass, which is determined genetically. That is determined by your birth weight. So all of us, not everybody has adequate number of nephron mass, and this is not reflected in the serum creatinine test initially. So when these patients are loaded with excessive protein intake, especially these dietary supplements and protein supplements containing creatine, some of these patients can develop hyperfiltration injuries. They start developing proteinuria, and they can go into chronic kidney disease because their low number of nephrons cannot manage such a high protein load. So it is difficult to kind of identify which patients will develop this, but then it is better to refrain from using these excessive protein supplements.
And my next question is that, there can be a mismatch between what we see as the creatinine levels and what is the GFR for the patients. So if we find patients whose GFR is under 30, but the creatinine is still seen as 2 to 4 and no other signs of volume overload or any such things which are detrimental. So in such patients, are they continued on the medical management, or you start considering renal replacement therapy?
So ma'am, now all over the world, the trend is we continue the final renal replacement therapy like dialysis or kidney transplant is considered only when the GFR falls to very low, like 5 or 6 ml per minute, especially when they start becoming symptomatic. This doesn't mean that we don't counsel these patients early on. So we start counseling at GFR of 25 to 30 ml per minute to either have an access to, kind of AV fistula, or, prepare them for dialysis and prepare them for kidney transplant. So we start counseling, but the medical management continues right till the time they become symptomatic. There is no advantage of starting dialysis earlier. Diabetic patients may become symptomatic at higher GFRs compared to patients with other causes of chronic kidney disease. So these patients may start dialysis a bit early at higher GFRs, but then the usual dictum is to wait as long as we can wait. There is no rush. This same applies to ICU patients with acute kidney injury. There is no advantage of starting dialysis earlier at any point of time.
Thank you so much, Dr. Nikalji. You've been really wonderful, and you have explained everything in great depth. And it is our privilege to present to you with this certificate of appreciation. Sir, could you please stop your screen sharing so that I can start mine? Yes. Yes. So thank you so much, sir, and we are very happy to present to you the certificate of appreciation for taking this excellent session for medical professionals on from CRF to kidney transplant during Organ Donation and Transplant Symposium DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee today on 11 September 22, and it has been a pleasure to listen to you. Thank you so much, sir. And with this, thank you so much, sir. So with this, since we are one session earlier once again, and our next speaker, Dr. Sanjeev Zadav, has gracefully accepted to take this session. So we move on to our next session. A report on burden of chronic respiratory disease in India in the Lancet Global Health suggests a disproportionately higher burden in India, that is 32% of the global chronic respiratory disease burden. In India, lung transplantation has come of age from its humble beginnings in 1999, where Dr. K.M. Cherian performed the first double lung transplantation and the first combined heart-lung transplantation, to the current scenario spanning over a period of 22 years. Several advancements have taken place to make lung transplantations a safe operation for patients with end-stage lung disease. To speak on end-stage lung disease and lung transplant, we have with us Dr. Sanjay Zadav. Please allow me to share my PPT. Just 1 minute. Yes. So Dr. Zadav is MBBS, MS, MCH, DNB. He is adult and pediatric cardiac surgery fellowship. He has done from Australia. His heart-lung transplant fellowship has been done from Australia. He is director of heart-lung transplant, Apollo Hospital, Navi Mumbai. He has pioneered heart-lung transplants in Maharashtra and Western India. He has pioneered uterus transplant in India. He is only surgeon in the world to do heart, lung, kidney, and uterus transplants. He has experience of more than 6,000 cardiothoracic surgeries, 68 heart-lung transplants, 2 uterus transplant, and 350 kidney transplants. It's a pleasure to have you over here with us in DAAN Fest, Dr. Zadav, and the dais is all yours.
Thank you, Dr. Archana Pate and Maharashtra IMA. This is a great opportunity. I'll just start sharing my slides. Right. This is an excellent forum that Maharashtra IMA has created for organ donation awareness and surgery for end-stage lung disease. There are 4 surgeries most commonly done for end-stage lung disease. That is LVRS, lung volume reduction surgeries, emphysema transplant. Now, fluorodesis is to reduce the gap between the visceral and parietal pleura to avoid future accumulation of pleural fluid. Bulectomy is excision of emphysematous bulla to reduce the dead space in the lung, and so that the other part of the normal lung will start functioning. And so most common, this is a photograph of lung volume reduction surgery that we have done in one of our patients in Apollo. This is a thoracoscopic bulectomy that we had done. Common in conditions in which lung transplant is advocated is COPD, alpha-1 antitrypsin deficiency. We don't see much in Indian subcontinent. That is, this is obstructive lung disease. Cystic fibrosis, we don't see much in Indian subcontinent. Restrictive lung disease, this is a very common spectrum, ILD or IPF, idiopathic pulmonary fibrosis, and patients who are having pulmonary hypertension, either primary pulmonary hypertension or Rosen-Mengeras syndrome due to congenital heart disease, where continuous left to right shunt increase the pulmonary vascular disease in the lung and causing severe pulmonary hypertension. So, what are the recipient selection guidelines? Patients who are extremely symptomatic patients and having clinically and physiologically severe lung disease. Physiologically, in terms of having severely deranged pulmonary function test, and who are having limited life expectancy, as you see them clinically around 12 to 24 months, but still who are having a good skeletal muscle mass and having ambulatory rehabilitation potential, and no other medical or surgical treatment is effective in these patients. So they are given maximal medical therapy or a maximal surgical therapy to treat this condition, and still they are symptomatic. Good nutritional status, good mental state, and adequate financial. So there are various scores which have been used theoretically in most of the clinical conditions like COPD or pulmonary hypertension. Bode score is used in COPD, which consists of body mass index, obstruction to airflow, dyspnea, and MMR scale, and exercise testing. So there are various score: European score for pulmonary hypertension, phase score for cystic fibrosis and bronchiectasis, MRC scale for dyspnea. But looking your decision for referring patient to lung transplantation, pulmonary function test, and pulmonary artery pressure, which can be easily, pulmonary artery pressures can easily be seen on 2D echo. Pulmonary function tests are easily available across the labs. Clinical examinations suggest that patient is deteriorating fast. It becomes symptomatic NYHA class 3 or 4, and patient's nutritional status is going down. Patient is becoming cacaxic. So all this thing is required. All these things are required to send this patient for lung transplant, and early referral is exceptionally important. These patients, as we call it, obstructive disease, Bode score more than 5, FE1 after bronchodilator going down less than 30. Hypoxia less than below 60 on ABG, and PCO2 is going above 50. Patients are developing secondary hypertension because of COPD, and rapid decline in general condition, and repeated hospitalization due to exacerbations in COPD attacks. This requires an early referral to higher centers or a cardiothoracic surgeon or transplant surgeon. Patients with idiopathic pulmonary fibrosis, FEV1, which is going down to 30% after bronchodilator, hypoxia less than 60, hypercapnia, increased frequency of exacerbation in pulmonary. When patient is getting this in IPF patients or ILD patients, you must refer them to higher centers or cardiothoracic transplant surgeon, lung transplant surgeon early. Patient with IPF DLSU is important because this is a restrictive lung disease, and reduction in the diffusion capacity of carbon oxygen, forced vital capacity going down than 60%, and oxygen saturation getting down to 88%. 6-minute walk test are classical indications for referring them for higher centers for transplant. Pulmonary hypertension patients whose pulmonary artery cardiac catheterization, right atrial pressure is going above 15. In pulmonary artery patient is going above 50. Cardiac index, cardiac output is going down, and patient is becoming exceptionally symptomatic in recent months, and declining 6-minute walk test are a classical indications to send them for a transplant. So what are the contraindications for lung transplant? There are absolute contraindications when patient is acutely ill or when patient is hemodynamically unstable. In that situation, even if you do lung transplant, success are not, it's difficult to achieve success in lung transplant. So when the patient is having severe other organ diseases like cardiac, kidney, brain or liver, patients are not candidate for lung transplant. Patient who are having uncontrolled sepsis or metastatic cancer, patient who continues to smoke, patient who is psychologically unstable, having social problems, and patients who are non-compliant to the treatment. This is very important, that patient who needs to have an adequate IQ, who should have a good social support and adequate finances to undergo lung transplant and to look after themselves after lung transplant. There are related indications as well. Age is one of the good related indications. More than 6 results are.
May I interrupt, Dr.
Patients
Jadhav?
who are extreme obese. Yeah.
Dr. Jadhav, may
Sorry,
I
yeah,
interrupt,
madam.
please? Sir, your
Yes,
voice
yes.
is cracking. If you could just switch off your video, sir, we'll be able to hear you more clearly. There is some network issue at your end.
Right. Switched off the video.
Yes,
I
sir.
think I am audible.
Yes, you are better audible, sir.
Okay, great. Thank you.
Right, sir. Right, sir.
So contraindications, mera age, we don't accept patients more than 60 years of age. Patients who are on ventilator dependent, patients who are on high dose of corticosteroids. These patients subset who are on high dose of corticosteroids, very high chances of they will have bronchial dehiscence after lung transplant. Patients who have psychosocial issues, infections, extreme body weights, either low or high, and extrapulmonary organ dysfunction. So this is International Society of Heart-Lung Transplant slides, which shows that the majority of indications for lung transplant, single lung transplant, are COPD and IPF. Double lung transplant, again COPD and IPF are the major indications for transplant. And you can see heart-lung transplant is a surgery which have got success in 21st century only, and the survival is more better in 21st century after availability of good immunosuppression, surgical techniques, and surgeons, intensivists, anesthetists had now a very good experience of doing this. And that is why the survival is better in 21st century for a heart and lung transplant. You can see from this slide, the median survival for heart and lung transplant in adults almost 6 years and pediatric 5.5 years. So what are the choices of lung transplant, single versus bilateral transplants? See, when you are using a single transplant, organ donation occurs for both lungs. So 2 patients can get benefited out of 1 donor. And single lung transplant we usually prefer in patients who are more than 55 years of age and very high risk of when they're surgically high risk, previous surgery has been done, and there is a difference on VQ scan prior to surgery. It suggests there is only 1 organ which is one lung which is damaged more than the other lung. The results are better in this older age group because the operation is limited. It is done quickly, and hemodynamic disturbance is less, metabolic disturbance is less in these patients. By young patient would probably go for bilateral lung transplant because of better survival benefit in bilateral lung transplant. Cystic fibrosis is one condition which usually needs a bilateral lung transplant since it's a very infected case. If you do single lung transplant, it quickly get infected from the infection on the other lung. IPF, single lung transplant can be done. PPH, primary pulmonary hypertension with heart damage, it is an ideal situation where heart-lung en bloc transplant should be done. But single lung transplant, because of the scarcity of the donors, can be done when heart is good and good in function with no morphological damage to the right ventricle. Single lung transplant can be done. So usual choice of procedures, interstitial lung disease, single lung transplant can be done. Obstructive airway disease, single lung transplant can be done. Younger patients who are 60 years, single lung transplant can be done. Bilateral lung transplant usually done in septic patients, bronchiectasis or cystic fibrosis, patients who are lesser than 50 years of age with COPDs, and heart and lung en bloc transplant in Eisenmenger's and primary pulmonary hypertension. So I won't go in detail since this the idea of today's symposium is to organ donation rather than understanding the surgical technique. I won't go in detail about what happens at donor hospital or a recipient hospital, but normally what we see is patients' blood group should match donor and recipient, and chest X-ray should be good. There should not be any infection on blood and urine and bronchial secretions, tracheal secretions, and hemodynamics are good. ABG should be good. ABG should be more than 300 on 100% oxygen. Lung compliance should be good. So donor should be less than, we usually accept donor lesser than 55 years of age. That is a standard world criteria. Beyond 55, we called it the extended donor criteria. ABO compatibility should be there, clear chest and size matching. So we cannot accept 110 kg donor lungs for a patient who's 50 kg weight recipient. So size matching is also very important. So oxygenation, I told previously that it should be more than 300 on 100% oxygen on PEEP of 5. So we have had extensive sessions on brainstem death, and I won't go in detail about surgical part. What we usually observe in donor while retrieving lungs is ABG should be good, airway pressure should be good, bronchoscopy findings should be good. There should not be any atelectasis, collapse, or intrabronchial issues like tumors. Chest X-ray, CVP should be good. And when you disconnect ventilator, the deflation of the lung should be good. On examination, while on table, when you are retrieving, there should not be nodules or metastasis or atelectasis or adhesions in the lungs. And when you flush the lung with the retrieval technique, we use prostaglandins, Perfadex. Perfadex is a preservative solution. For heart, we use custodial, and for lung, we use Perfadex solution. I won't go in detail about this. So advantages of single lung transplant are 2 recipients can get benefited because there is a long waiting list for lung transplants, and 1 organ can give life to 2 patients. So this is the advantage of doing a single lung transplant. It has a better 1-year survival and less short-term morbidity. So this is very doing a single lung transplant is in vogue because 80% of the lungs which come from donation are not having a good criteria for donation. So only 20% are available in pool. So that is why this single lung transplant is in vogue, because it gives life to 2 patients. This is the general incisions which are used for lung transplant, either median sternotomy or a clamshell incision where you incise thoracotomy, sternotomy, and donated lung that I have taken a photograph which I have retrieved. This is photograph of a video of a lung which is retrieved, and I am giving pulmonoplagia through retrogradely through pulmonary veins. And this is another video where I am retrieving heart and lung en bloc, and then we divided heart separately and lung separately for transplant. Just fast forwarding the video. I'm taking it out of the chest cavity. So we preserve in a ice, and so normally when you are taking out a lung from a distance, this was a photograph. I took it in a aeroplane which has a twin engine, very fast aeroplane, and there was a record on my name while taking out from Chandigarh to Mumbai, which is around 900 nautical mile or 1600 kilometer. We removed a lung and transplanted in Mumbai. So again, these are recipient issues, anesthesia. I don't go. Immunosuppression is similar what we use in kidney, liver, heart, or lung, all vital organ transplant. Majority of institute use basiliximab, which is a monoclonal antibody as an induction therapy for immunosuppression for interleukin 2 receptors, and then antimetabolite MMF and tacrolimus and methylprednisolone steroids. So these are the immunosuppression pan-organ transplant is similar. Sometimes cardiopulmonary bypass or ECMO is required when there is unstable hemodynamics, patient is having hypoxia during transplant or hypercarbia during transplant, acidosis. In such situations, or patient require any heart operation simultaneously. In those situations, we put the patient on cardiopulmonary bypass and then do the lung transplant. So this is a general diagram to make you understand how lung transplant. Single lung transplant can be done through the thoracotomy. Then bilateral lung transplant can usually done from the median sternotomy or a clamshell incision. So this is a general understanding, general photograph where a lung transplant involves joining of pulmonary artery with a native recipient's pulmonary artery, bronchus with the recipient's bronchus, and pulmonary veins to the left atrium of a recipient. This is a photograph of a clamshell incision for lung transplant. I won't go in detail of surgical issues. So median survival after lung transplant is almost 6 years. So lung transplant is a safe procedure, though it is very complicated. It can be done safely, provided that institute has got excellent backup and human resource is well trained. The main issues are primary graft dysfunction, rejection, and infection. Airway complications include dehiscence, stenosis, bronchomalacia, which can be dealt by interventional pulmonologist. Rejection, which consists of acute and chronic. The primary treatment in this patient is use of steroids, methylprednisolone. So lung is an lung transplant. The donated lungs are denervated organs. So cough reflexes depressed, mucociliary clearance is depressed, lymphatic drainage is disrupted, and that is why they are more prone for infection. And So majority of outcomes are gauged by survival benefit of this patient. As I told you, almost 6 years survival, mean survival, and quality of life that patient is having. And the quality of life is measured depends upon how much is the pulmonary function test are improved. So in last decades, lung transplant has rapidly evolved, especially in centers, third world country as well. And it is pretty doing very well as a technique, surgical technique. So take home message probably is, it is very important. See, in the kidney transplant, nephrologist is in charge. Liver transplant, hepatologist is in charge. But in heart-lung transplant, cardiothoracic surgeon and a transplant surgeon. A cardiothoracic surgeon who is trained in transplant surgery is in charge of this heart-lung transplant. So early referral to the heart-lung transplant surgery is exceptionally important to save patient's life. And before the FEV1 goes down to 50%, it is important to refer this patient. Any patient who are extremely symptomatic, it should be referred to the heart-lung transplant surgeon. And antifibrotic medications are mainstay in IPF patients. So far, we have done 68 heart and lung transplant, 350 kidney transplant, 2 uterus, and more than 6,000 cardiothoracic surgeries. We have pioneered heart and lung transplant in Maharashtra and Western India, pioneered uterus transplant in India. It is a revolution for a non-vital organ transplant. We were thinking about heart, lung, kidney, and liver up till now. But after doing a uterus transplant, and which is ahead of any Western country like USA. USA had done 2 uterus transplant after us, and both have failed. But we have done 2 uterus transplant in Pune, both were successful. And there was an article in the paper, so it's a uterus transplant that we have done in Pune, the first of the kidneys uterus transplant. Back to back, we did 2 uterus transplant, and a baby is also delivered after 1 year. This is the first year, 1 year photograph of that baby. And so it is important that we refer the patients as early as possible when patients are extremely symptomatic, losing their weight, reducing pulmonary function test, as early as to the cardiothoracic. Actually, my motto to come to this symposium is to appeal to most of the IMA fraternity that we have in Maharashtra exceptional infrastructure. Maharashtra being the #1 state of the country, we have excellent infrastructure, excellent doctors, surgeons, and we have given results, and we have given reproducible results in heart-lung transplant, complex cardiac surgeries. We have been doing bypass surgeries, complex bypass surgeries, and valve surgeries, and other cardiothoracic surgical procedures, lung surgery, with international standards. So that is our day-to-day job. So in Maharashtra, we have all the facilities, and we should do our patients in Maharashtra. So referring patient to South India probably gives more trouble to this patient, going and staying there for 6 months, getting investigated there to stay. There is a massive cost involved with this. So I would urge all the medical fraternity that if you refer these patients to centers who are doing this and giving results, probably will get more benefits to your patients than referring them to South India. Thank you very much.
Thank you, sir, for that elaborate session on lung transplant and the end-stage lung disease. I think even though everybody's heard about it, the concept is relatively lesser known to people, and you gave quite an elaborate idea about everything about lung transplant. So since we are running slightly behind schedule, we will not be taking question answer sessions for this. It is my great pleasure to just 1 second. Yes, to present the certificate of appreciation to Dr. Sanjeev Zada for taking this excellent session for medical professionals on end-stage lung disease and lung transplant during Organ Donation and Transplant Symposium DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. And we sincerely thank ACCP West Zone and Dr. Shantesh Kaushik for being instrumental in educational association with this session. So thank you so much, Dr. Sanjeev Zadav, and it was a pleasure listening to you. Thank you so much. And we move on to our next session. Small bowel and pancreatic transplants are complex procedures requiring good expertise. Most pancreatic transplants are done to treat type 1 diabetes. A pancreas transplant offers a potential cure for this condition, but it's typically reserved for those with serious complications of diabetes because the side effects of a pancreas transplant can be significant. In some cases, pancreatic transplant can be done for other conditions, where a small bowel, that is intestinal transplant, is an operation to replace a shortened or non-functioning small bowel with a healthy bowel from a donor. To tell us about the new frontiers in small bowel and pancreatic transplant, we have with us Dr. Gaurav Chaubal. Please allow me to share my PPT. Yes. So Dr. Chaubal is Director, Liver, Pancreas, Intestine Transplant Program and Hepatobiliary Surgery at Global Hospital, Parel. He has several firsts to his credit in Maharashtra that includes pancreas transplant, adult dual lobe living donor liver transplant, diseased and living donor small intestinal transplant, simultaneous pancreas and kidney transplant, auxiliary liver transplant for pediatric acute liver failure, and monosegment graft transplant for pediatric transplants for infants. He was a gold medalist in MS General Surgery. He has done MCH, that is Surgical Gastroenterology from AIIMS, New Delhi, fellowship in multi-organ abdominal transplant surgery from Duke University, and GI Surgical Oncology from Tata Memorial Hospital. He is trained in liver surgery at Seoul National University and Samsung Medical Center, South Korea. It is great to have you here, Dr. Chaubal, and may I please request you to carry forward the session?
Yeah, thank you. Thank you, Dr. Patel. And, good morning to everyone. I'll be talking about pancreas and small bowel transplants today. Are you able to see the slides?
Yes.
So abdominal transplants, the field is not new. The abdominal transplants have started as early as the 1960s. So it's been almost 50 to 60 years since the first abdominal organ transplant took place. But since then, there has been remarkable progress which has happened in the field of transplant immunology, organ preservation and transplant surgery, which has led to continuous betterment in the outcomes of transplant. So we all know about liver kidney transplants. What is novel to our part of the world is pancreas and intestinal transplants, which are relatively new abdominal organ transplants. So I'll be talking first about pancreas transplantation. So we need to know about the indications of pancreas transplant, how it is done, and what are the outcomes. So as you said rightly, the commonest indication for a pancreatic transplant is a type 1 diabetic. Now, not everyone, as you know, who is suffering from type 1 diabetes will require a pancreatic transplant, because there are excellent medical management which is available in the form of insulin pumps, high quality monitoring, and not all patients with type 1 diabetes need a pancreatic transplant. So who is the subset of patients who really need a pancreatic transplant? So they are the ones who are poorly controlled on insulin. They have brittle diabetes, get recurrent episodes of diabetic ketoacidosis, recurrent admissions, or who have hypoglycemic unawareness, who have these episodes of fainting and dangerously low levels of blood sugar. And this is because of loss of the counter insulinemic response. They also have loss of the glucagon hormone, which is secreted from the pancreas. And that is why these patients have these episodes of hypoglycemic unawareness. And then there are these subsets of patients who have end stage organ damage. That is, in spite of being on insulin, they will have end organ damage in the form of crippling nephropathy, they will end up on dialysis, or who have neuropathy and retinopathy. So these are the patients in which not only their quality of life is compromised, but their survival is also come down. So if you have a patient of chronic kidney disease with diabetes mellitus, the average survival is not more than 4 to 5 years, and there is almost 16 to 17 years of life loss. The risk of mortality in chronic kidney disease is 2 times higher in a diabetic patient. Also, select patients with type 2 diabetes will benefit with a pancreatic transplant. So who are these patients? Now, these are relatively young patients who are less than 50 years of age and who have a type 1 diabetic phenotype. That is, their BMI is less than 30. They don't have insulin resistance. The C-peptide is less than 2. And their insulin requirement is less than 1 unit per kilogram per day. So select patients of type 2 diabetes will also benefit with pancreatic transplant. And one of the benefits of listing these type 2 diabetic patients is they will get a kidney early and they will get a good quality kidney, because the patients donors who donate organs for pancreatic and kidney donors, they are relatively young donors who are less than 40 years of age, and these kidneys will have a longer lifespan as compared to other deceased donor kidney donors. So how a pancreatic transplant is done? So this is a pancreatic allograft which is retrieved from a brain dead donor. So you can see that the entire pancreas is retrieved along with the C loop of duodenum and along with the spleen. So this entire pancreas is then transplanted into the recipient. So the native pancreas of the recipient is not disturbed. So native pancreas lies in place. This is a heterotopic transplant, and the pancreas is implanted in the right iliac fossa. I'll show you a short video. So this is how a pancreatic transplant is done. The pancreatic gland is lowered into the recipient's abdomen. And then you can see the vascular anastomosis being done. So the outflow of the pancreatic transplant is basically the portal vein, which is implanted into the IVC of the recipient. And the inflow is basically through a Y graft. So the pancreas has 2 arteries, the superior mesenteric artery which supplies the head and the splenic artery which supplies the body and tail. So both these arteries are made into a common inflow by using a Y graft of the common iliac artery of the donor. So this is how the vascular anastomosis is being done. This is the venous anastomosis, which is later followed by the arterial anastomosis. So survival after the pancreatic transplant is excellent. You have almost 90% 1-year survival and more than 80% 5-year survival after the pancreatic transplant. And the outcomes of the pancreatic and the kidney transplant are only getting better with time. So we were fortunate enough to do Mumbai's first pancreatic transplant 2 years back. And since then, we have performed a number of combined pancreas and kidney transplants. The second transplant, which I would like to talk about, is a small bowel transplant. So the commonest indications of small bowel transplant are patients who have small intestinal failure. The small intestinal failure can either result because of loss of large amount of intestine because of some insult, or because there is a functional disorder of the intestine. Either the intestine is not able to absorb the nutrients or there is some motility disorder. The commonest indications in children is necrotizing enterocolitis. So this is seen in the premature babies, in which because of hypoxia, the intestine develops patchy gangrene and a lot of intestine has to be resected. Or sometimes you have motility disorders in the form of neurological or myopathies of the intestine in which there is dysmotility. And in adults, the commonest indications are mesenteric ischemia. You have mesenteric artery thrombosis because of atherosclerosis. As is common with atherosclerosis in other organs like myocardial infarction, you have mesenteric ischemia of the intestine also. And the other conditions are midgut volvulus and mesenteric tumors. Midgut volvulus is typically seen in the mid-age population, in which you have malrotation and the whole intestine gets twisted on its axis. So the blood supply of the intestine is completely compromised, which leads to complete gangrene of the intestine, and that leads to bowel loss. And the third indication is mesenteric tumors. Sometimes you have these desmoid tumors, which are invasive tumors of the mesentery, which cause compromise of the blood supply and loss of the bowel. So once these patients have intestinal failure, they are not able to eat normally because the digestive and absorptive functions of the intestine are compromised. So these patients are put on total parenteral nutrition. Total parenteral nutrition has its own set of problems. It has to be given through central lines, and the lines have a problem of serious bacterial and fungal infections. The big vessels, that is the internal jugular vein or the subclavian vein, the femoral vein, because of continuous presence of a foreign body, can get thrombosed, and you have vascular thrombosis. TPN also has the lipid component, which causes fatty liver and then progressive cholestatic injury of the liver. So over time, they start developing liver dysfunction and they start developing liver cirrhosis. So that in itself is fatal. And in India, bigger problem is the cost. TPN is expensive. We do not have facilities of manufacturing or tailoring TPN. So TPN bearing the cost becomes difficult because TPN is not covered by insurance. So these are the complications with total parenteral nutrition. And that is the reason why these patients need to undergo a small bowel transplant. So a small bowel transplant can be done in two ways. You can get a bowel from a deceased donor or a brain dead donor, or you can also get a living donor small bowel from one of the patient's family members. So what are the differences between a cadaveric and a living donor intestinal transplant? In the cadaveric transplant, the entire intestine is harvested from the duodenojejunal flexure to the IC junction. Whereas in a living donor, you need only 150 to 200 centimeters of intestine to be transplanted. A lot of people find it difficult to believe that someone can donate an intestine also. But for the donor, you just need to resect 40% of the intestine, and the donor can have complete bowel autonomy. They don't need to be on TPN. The recovery period is not more than 4 to 5 days, and they can go back to their normal life in around 15 to 20 days. So living donor intestinal transplant is very much a reality. This is how the small bowel allograft looks like. This is the entire small bowel allograft, which is retrieved from a deceased donor. And this is immersed in our organ preservative solution. The inflow to the small bowel is through the superior mesenteric artery, and the outflow is through the superior mesenteric vein. This is the recipient surgery. So the small bowel is implanted onto the aorta and the IVC of the recipient. Typically, the abdomen of the recipient is completely empty. There is no intestine left. So you just have the vessels in front of you and the kidneys. So we have to expose the vessels for the implantation of the small bowel. I'll show you a short video of a small intestinal transplant. This was one of the transplants which we had done, a deceased donor transplant for a 40-year-old male. So you can see the aorta and the IVC being exposed. We put a clamp on the aorta and make an opening with the aortic punch. This is the opening in the aorta. And then again, to implant, we use a vascular conduit. So this is the donor iliac artery. The iliac artery is joined to the aorta. This makes the implantation process a little easy because the aorta is a very deep structure in the body, and a small bowel graft is a huge graft as compared to the other grafts. You have almost 600 centimeters of bowel which you have to implant. So to make it easy, this is what is done. This is the vascular anastomosis of the conduit, which is complete. Then they put a clamp on the conduit. And this is again, we put a venous conduit on the IVC of the recipient. So again, the donor iliac vein is used and is anastomosed to the IVC of the recipient. This is the donor iliac vein graft. This is the venous anastomosis which is being done. So now you can see this is the actual small bowel graft which is lowered into the abdomen. And what is being marked in blue is the supramesenteric artery of the graft, which is anastomosed to the conduit. This is followed by the venous anastomosis. And then we release the clamps and the graft is reperfused. So this is the revascularized graft. Here you can see both the anastomosis, the arterial and the venous anastomosis. And the revascularized graft looks like a perfectly normal bowel. You'll see a very well vascularized pink graft which has good peristalsis on table. So this is our first experience when we started in 2020. This was actually in the beginning of COVID in March 2020, when we had our first patient who was a 27-year-old male who had midgut volvulus and who underwent a deceased donor intestinal transplant. So this we have published as the first experience from Western India. And this is our first living donor intestinal transplant. So this was again in the peak of COVID, a 9-year-old child who had suffered from COVID 3 weeks back. And because of the COVID-induced mesenteric thrombosis, the entire small bowel was gangrenous. And it was very difficult to manage this child because he was only 9-year-old. He wanted to eat. And in the peak of the COVID era, there were no donors available. So there was no experience of a living donor intestinal transplant from India. So we discussed this with the family. We discussed the options. Then the father came forward as a donor. And we were finally successful in doing a living donor intestinal transplant for this child. And he's almost now more than 2 years out. And he's doing very well. And this got accepted for publication in the American Journal of Transplant, which is the highest impact factor journal in the world of transplantation. This is the video of the child taken last year in Diwali. He's able to lead a normal life, eat well, go back to school, play with his friends. This is how gratifying the intestinal transplant is. So the patient and the graft survival is more than 95% at 1 year and almost 70% at the end of 10 years. The quality of life is good because you get independence from the family members, you can attend school, able to do all routine activities and enjoy playing sports. So this is our experience of transplants so far. Almost done more than 600 liver transplants. More than 80 liver transplants being done this year in the last 6 to 7 months. So far, we have done 9 pancreatic transplants, out of which 8 were for type 1 diabetes and 1 was for type 2 diabetes. And we've done 10 small intestinal transplants, out of which 8 were deceased donor and 2 were living donor. Thank you all for your patient hearing.
Thank you, Dr. Chawal. That was indeed wonderful. You mentioned there that one pancreatic transplant was done for type 2 diabetes. So in which type 2 diabetic patients this is considered?
Type 2 diabetes who have a type 1 phenotype. Basically, these are like the maturity onset type diabetes mellitus. So if you see a type 2 diabetes, the phenotype is very different from a type 1 as well, because they are obese, they have insulin resistance. But there are some type 2 diabetics who resemble the type 1 phenotype. They are not obese, the BMI is less than 30. If you see the C-peptide, it is less than 2. And insulin requirement is not more than 1 unit per kg per day. So these are the patients who will benefit with the pancreatic transplant. And these are the patients who are basically having type 2 diabetes with renal failure. So when you combine it with the kidney transplant, the survival of the kidney transplant as well as the overall survival of the patient is improved. They also get kidneys which are very good in quality, because the pancreatic donors are usually young donors. The longevity of the kidney transplant also is much longer.
Okay. And how does the insulin requirement remain after pancreatic transplant?
They don't need insulin anymore.
Okay.
So,
And this idea about leaving this, you said that the original pancreas are left in situ and these new pancreas are, transplanted. So what is the idea behind this?
so see, even in the kidney transplant, the original kidney is not.
Exactly.
So it's a heterotopic. Heterotopic means it's put in a different position in the body from the original location. So if you remove the entire pancreas, it itself is a very complicated process, because you have to remove the duodenum, the pancreas, then do various intestinal connections. Like you have to do anastomosis of the stomach to the jejunum, the bile duct to the jejunum. So that becomes a very complex process, and there is no advantage of doing it. Rather, there is a disadvantage, because you prolong the surgery, you prolong the morbidity, and your basic requirement is insulin. So even if you put it in a heterotopic location, the surgery becomes easier, faster, and you don't add to the surgical morbidity.
Okay. Thank you so much, Dr. Chaubal. You have been wonderful, and it gives me great pleasure. Sir, could you please, screen share. If you could just stop your screen share. Yeah. So thank you, Dr. Chaubal, for taking this wonderful session for our doctors on new frontiers in small bowel and pancreas transplant during DAAN Fest organized by IMA Maharashtra State Organ Donation Committee today on 11 September 22. Thank you very much.
Thank you, ma'am.
So
Thank you,
moving on to the next session. The magnitude of blindness is enormous. India has the largest population of the world's blind, with over 45 million visually impaired and 12 million of them totally blind. Every year, 1 million more people are added to these statistics. Fortunately, nearly 80% of them can easily be cured if only they can receive the treatment. As per the National Program for Control of Blindness and Visual Impairment, approximately 10 lakh people are suffering from corneal blindness and waiting for corneal transplants. There is a huge gap between the need and availability of donated tissues, which are mainly due to lack of awareness and myths associated with eye donation. So to enlighten us on eye donation, see the world even after you depart, we have Dr. Shilpa Joshi. Please allow me to introduce her. Give me a minute. I'll share my screen. Yes. Yeah. So Dr. Joshi is head of the department, cornea and medical director of Eye Bank at HV Desai Eye Hospital. Done over 20,000 cataract surgeries and over 1,000 keratoplasties, including optical, therapeutic, DALK, DACK, and keratoprosthesis. Active involvement in teaching and training of postgraduate students, cornea fellows, and FACO trainees. Many publications in national and international journals. She has many awards to her credit, including the prestigious V.K. Chitnis Oration Award of MOS and many Best Paper, Best Video awards. She is principal investigator in multi-centric clinical trials. It's a pleasure to have you over here, Dr. Joshi. Could you please carry forward the session? Madam, you are made the co-host. You'll be able to share your screen. Yes, madam, unmute yourself, please.
Yeah. Am I audible now?
Yes, ma'am. If you can just make the screen whole, like the full screen. Yeah, it is visible.
Just 1 second. Just 1 second. Sorry. Is my screen visible now?
Yes, ma'am.
Yeah. Thank you very much, Dr. Archana, for having me here to be a part of this prestigious symposium on organ donation. And it's quite a humbling experience to hear from all the expert panelists and the various transplant surgeons. I work in a dedicated eye hospital, and my experience and my perspectives on this are slightly different, and which I would like to share in my presentation on corneal transplantation and eye donation. So cornea, as we know, is a clear transparent dome in front of the eye. It's not just a watch glass like thing, as often said by the non-medical people. It's an elegantly simple but structurally complex structure. It is one of the important optical apparatus accounting for 2/3 of the refractive power of the eye. So any loss in the transparency of cornea by edema, scarring, or even inadequate tear film causes immediate reduction in vision, which is quite severe compared to the other diseases of the eye, which may not cause that sudden and that severe loss of vision. So as you mentioned, Dr. Archana, the magnitude of corneal blindness in India is very huge. We have about 6.8 to 10 million cornea blind people. About 1 million of them are bilaterally blind. It is the second leading cause of blindness after cataract and refractive error, especially in the rural and semi-urban parts of India and in the underprivileged population. Worst is that nearly 90% of them are children or young adults, which means that there is a huge economic burden on our society if we don't treat these patients. What are the causes of corneal blindness? In our kind of setup or in India, the commonest causes are the infections, which could be bacterial, fungal, or viral. Injury or trauma, penetrating and perforating corneal tears and wounds are also important causes. So are chemical and thermal burns, which are seen in the industries. The other causes are post-cataract corneal decompensation, post-glaucoma corneal decompensation, some of the degenerative diseases of the cornea. Childhood blindness again accounts for a major portion of the corneal blindness. And the causes in children or young adults are the ectatic corneal dystrophies like keratoconus or keratoglobus, then the stromal dystrophies like macular granular dystrophy, and the endothelial dystrophy like Fuchs corneal dystrophy. Other causes of childhood blindness are that which we see is because of intrauterine infections like congenital rubella syndrome, which we often see. Another cause is congenital hereditary endothelial dystrophy, in which the child presents with a usually bilateral involvement and ground glass corneas. And vitamin A deficiency and malnutrition are also commonly seen. Coming to indications for keratoplasty, basically there are three indications. One is for the optical reason, one is for therapeutic, and the third one is for tectonic, although this division is not absolute, and many times there is an overlap between the indications in clinical scenarios. So optical penetrating keratoplasty basically means full thickness replacement of the cornea for improvement in vision. It is done basically for post-cataract corneal decompensation, then in healed corneal ulcers with scarring, adherent leukomas, which is post-perforation, and corneal dystrophies and degenerations. Therapeutic keratoplasty is basically to remove the infectious load and to resolve the microbial keratitis in cases which are refractory to conventional medical therapy. All the cases of perforated corneal ulcers, especially those with extensive infection and endophthalmitis, they should be treated with therapeutic keratoplasty. Tectonic keratoplasty is basically to restore or preserve corneal integrity in eyes with severe structural change, such as stromal thinning or desmatocele, which may be because of immunological conditions like rheumatoid arthritis or Murray's ulcers, the sterile corneal melts which occur, or it may be secondary to the tissue loss in traumatic corneal injuries. So corneal transplantation at the moment is the only definitive treatment available for treating all these conditions. Traditionally, corneal transplant has been described as the most successful among solid organ transplants with a 90 to 100% success rate. But however, this is only half true, because the literature describes these cases, these corneal transplant in cases of keratoconus or corneal dystrophies, which are generally quiet conditions, and they have quite a good prognosis. The prognosis may not be very good in vascularized corneas or perforated corneal ulcers or previous multiple failed grafts. So pre-existing corneal pathology has a direct bearing on the outcome. And needless to say that post-operative management and follow-up go a long way in determining the survival of the transplant and success rate. So this was a paper published by us describing initial results of our first few hundred transplants. And what we learned from this is that the loss of immune privilege in cornea has important connotations for graft survival, especially in clinical scenarios whether the other eye is irreversibly blind. So graft rejection is not just an ocular phenomenon, but obviously it involves the antigen presenting cells, the surrounding lymph nodes, the T cells, etc. So corneal grafts on high risk recipient beds like vascularized cornea, inflamed eyes, previous failed grafts, etc. Just the topical steroids are not sufficient for the management. Even systemic steroids may not be sufficient, and patients, especially bilaterally blind ones, may need a systemic immunosuppression. So our current standard practices are quite similar to the other transplant surgeons, and in most of the times we do this in consultation with them, with the transplant surgeons and physicians. And the drugs that we use are again mostly the same. Cyclosporin A is what we use commonly in corneal transplants. Methotrexate is also a very cost-effective and a good option in corneal transplants. That's what our studies, one of the studies that we have done at HVSI indicates. MMF, azathioprine, tacrolimus, especially the ointments of tacrolimus, we use quite often in the treatment of in the prophylaxis of rejection. And treatment of graft rejection is obviously steroids by all the possible routes: IV methylpred, intracameral, anterior subtendons, topical, and oral steroids. In recent years, there has emerged a concept of component corneal surgery. This is basically to optimize the results in corneal transplants, especially high-risk cases. Our knowledge in this field tells us that full thickness replacement of the cornea is not needed when only certain layers of the cornea are involved. So we have shifted to selective lamellar keratoplasty, which may be anterior lamellar surgeries, in which basically the anterior 2/3 of the cornea is replaced, diseased portion of the cornea is replaced, like DALK, SALK, which is superficial anterior lamellar keratoplasty. Or it may be posterior corneal surgeries or endothelial keratoplasties for diseases affecting the Descemet's membrane and the endothelium. So advantages of this are basically avoidance of open sky surgery related severe complications seen in conventional PK, less chance of graft rejection because we are transferring less amount of tissue, better visual outcome, longer survival of the grafts, and one cornea can be used for as many as 3 patients, the anterior portion for certain indicated patients, the posterior cap for other patients, and the surrounding limbal epithelium for some other patients. So these are some of the DALK surgeries, anterior lamellar surgeries, which have been done for keratoconus, for scars involving the anterior 2/3 of the stroma, and for dystrophies. And these are the endothelial surgeries or DSEKs, which have been done for Fuchs dystrophy, for PBK following cataract, for now the indication has been extended to CHED also. And very important indication in our kind of setup is previous multiple failed grafts, where a full thickness corneal transplant is surely likely to result in rejection despite of the immunosuppression, which is a possibility. The more the number of grafts, more is the chance of rejection. So DSEK is a very good option for these kind of cases. Moving on to the concepts about eye donation and eye banking. As we know that there is a huge backlog of cases and there is addition of 25 to 30,000 new cornea cases every year. So approximately 2 lakh corneas are needed to take care of these patients. But all the eye banks in India are able to collect currently 45 to 50,000 cornea, meeting only 25 to 30% of the total requirement. So this is the eye donation statistics. As we see, mostly the eye donation, the concepts about it are more, awareness is more there in the west and the south regions, where a lot of work needs to be done in the other regions. Every year there are so many deaths and only 37 to 40,000 eyes are donated. Why? Because we have an opt-in system in India. Unlike other countries like Sri Lanka or USA, where eye donation after death is not optional, but it is mandatory by law. So as we must be knowing, Sri Lanka happens to be the biggest eye donation or biggest donor of corneas all over the world. These are some of the myths or questions, frequently asked questions by our patients or donor families. So my religion does not allow organ or eye donation. So this is totally false. All religions, they support eye donation. Eye donation will cause disfigurement, so it is not true. And most of the time we are now removing only the cornea or the corneoscleral rim instead of the whole globe or enucleation, which so there is absolutely no chance of disfigurement as artificial shell is placed after removal of the cornea. Now donation will be costly to the family. It's not true. Again, all expenses are borne by the eye bank. The procedure takes only 15 to 20 minutes. And as we said, only the corneoscleral rim is what is harvested and transplanted. So who can be the donors? In layman's term, any person of any age can donate. Generally, the eye banks have the donor age between 2 years to 75 years. But it is left to the discretion of the that particular eye bank and the medical director. Poor eyesight or patients using spectacles or diabetic patients, hypertensive patients, or patients who have undergone cataract surgery, they also can donate eyes. These are for basically for the donors and the relatives of the patient of the deceased before the eye bank team reaches there to harvest the corneas. So as we know that the corneas should be retrieved within 6 to 8 hours of the death, and both the eyes should be kept closed to avoid exposure keratitis and further damage or to the tissue. Now the NPCB and Eye Bank Association of India has given certain guidelines for the eye banks to function. And this is generally the organogram, which consists of a medical director, the eye bank manager to coordinate the activities, technicians, grief counselors, 24-hour vehicle with driver should be available. From equipment point of view, a slit lamp and a specular microscope are the mandatory requirements. Specular microscope is basically to assess the tissue and to assess the endothelium of the donor cornea. So this is the endothelial mosaic picture which we get in a normal healthy cornea, healthy donor. If this is not the picture and there is loss of severe cells or black areas seen in the endothelial mosaic, or the hexagonality is not retained, or there is polymegathism or pleomorphism, then that cornea is probably not healthy. And count below, endothelial cell count below 2200 is also a contraindication for optical keratoplasty. The counts corneas with counts between 2000 to 2200 can be used for therapeutic and tectonic reasons. Slit lamp examination is equally important to give idea about the overall quality of the tissues, and depending upon that, the tissue is graded into excellent, very good, fair, good, or fair. And accordingly, it is transplanted in the indications depending upon the clinical indications. Now, generally, which patients are given top priority? So those with bilateral blindness, bilateral vision less than 3/60, or bilateral visually impaired children are given priority compared to the, and bilaterally blind young adults, they are given priority compared to the other people. Of course, the emergency indications remain that therapeutic PK for perforated corneal ulcers, which should be given priority. Methods of corneal preservation. Previously, it used to be short-term methods like moist chamber. Then came the intermediate storage methods like NK medium. Nowadays, we use the modified NK medium, or we use the cornisol or optisol, which gives better preservation and can preserve the corneas for 7 to 10 days, making optical keratoplasty elective surgery. And there are long-term methods. These are practiced in the US, the organ culture medium and the cryopreservation. Now, these are the NPCB guidelines for donor screening. As we know, any active communicable disease is a strict contraindication, including HIV, active viral hepatitis, active septicemia. And as far as the ocular conditions go, any active inflammation like conjunctivitis, vitritis, uveitis is a contraindication. Tumors like retinoblastoma and malignant tumors of the anterior ocular segment is a contraindication. As far as the systemic condition go, malignancy, localized organ malignancy is not a contraindication provided there is a absence of metastasis. COVID has been a very trying period for all of us, including the cornea surgeons and the eye banks. And during the initial part of the pandemic, all the eye bank activities were halted and we were forced to use the glycerin preserved corneas for emergency conditions. However, slowly we have started to regain and regain our activities. And these are the guidelines which were given by our eye bank association during the COVID time. Now, NPCB and eye bank association and Orbis, they have given this three-tier community eye banking pyramid for the development of the eye banking in India, and especially the hospital cornea retrieval program. So as per their recommendation, or what they have proposed is that the in situ corneal rim excision should be practiced rather than enucleation, and this can be carried out by the eye bank technician alone. So a doctor is not always necessary for the eye bank calls, except obviously when the death certificate is not available. And they also propose to delink the transplant center registration from eye bank registration. So the concept is basically eye bank should be a standalone functioning unit, just like a blood bank. It can have collaborations with various multi-speciality hospitals, and the they should place the grief counselors in the such multi-speciality hospitals or government hospitals to promote the HCRP program. Because as we know that the voluntary programs or the voluntary home calls, in those the age of the donor is above 75 to 80, and those tissues are not very good for transplant purposes. So the focus should shift to hospital cornea retrieval program, which gives more yield of younger donor tissues, and obviously a greater detailed history, cause of death, etc. Is better available. So tie up with a multi-speciality hospital is a more sustainable model. Coming a little word about our HV Desai eye bank. We started functioning since 2005. In the initial part, our cornea retrieval was basically from the home calls or voluntary donations. But after that, a significant change occurred in the year 2014, where we were able to collaborate with the government hospital in Pune. And because of that, there has been a significant boost to the eye banking or HCRP program. And these are the numbers of the corneas that we have collected till 2019. Better than that is the utilization has also been quite good, especially after we collaborated with international eye bank called SightLife and the government medical college hospital in Pune. So we have this unique model of public-private partnership, which has served as a template and inspiration for many similar programs across the country. And we have a very holistic and visionary goal in sight, the elimination of treatable corneal blindness in Pune district and Maharashtra. So wherever any surgeon in Maharashtra needs a cornea for his patient, our eye bank is able to provide it. And we charge only obviously for the cornea preservation. There are no charges taken for keratoplasty surgery. So since the program started, we have collected 2,787 corneas so far. And more important than that, we have transplanted 2,000 91 corneas till date, which is a healthy 75% utilization, which is exceptionally higher than the national average of 46. And the corneas which are not able to use for the transplant, we use for the training purposes of the residents. These are the other HCRP centers which we are associated with. So this is a graph showing our collections and utilization. COVID has been a setback, but we are gradually recovering from it. Advocacy and public awareness is an important part of our iBanking activities. So we during the iDonation fortnight, we conduct various activities like cycle rallies and public awareness programs and slogan competitions, drawing competitions in the schools. And we visit our various HCRP partners and give presentations in the ICUs to the nurses, to the doctors, and to the other staff to create more and more awareness about eye donation. These are some of our patients. This girl with her corneal opacity since early childhood benefited a lot after the transplantation. This was a girl with CHAD who was not able to go to school at all because of poor vision. She also had glaucoma. So first she underwent surgery for control of pressure, trabeculectomy, and then optical keratoplasty. After that, her started going to school, and I'm happy to say that now she is doing her graduation and doing it with this thing has changed her life forever, for not only for her, but for her family as well. This is another girl with similar thing, CHED, who has also benefited a lot after the transplant surgery. This boy of Down syndrome, after the corneal transplant, life became much easier for him and his family members. So that is what we strive for, smiles and happy families. That is our goal. And this is our dedicated iBank team, who is so sincere and dedicated for this noble cause, that they are throughout the year, not only just for the fortnight, but throughout the year, they are busy in spreading awareness and conducting various awareness programs. And we all pledged to donate our eyes. As they say, Marave pari netra rupe urave. So we wish to remain alive even after we depart from the world. So this is in short about my experiences in eye donation, eye banking, and corneal transplant. Thank you very much for the time. Thank you.
Thank you, madam. Thank you for that elaborate session. And there's a query that would you have any idea about the eye banks in Mumbai and particularly in South Mumbai?
Mumbai has a central eye bank called EBCRC, which is at I think Haji Bachchu Ali Hospital, and they also have a dedicated eye bank, standalone eye bank in Thane, which is Sayara, which caters to, I think, Thane district. These are the eye banks in Mumbai, and we as HVDSI eye bank, we cater to Pune district and rest of the Maharashtra.
Okay, so there are quite less number of eye banks, if I may say so. So we need to even work more towards having more eye banks and of course increase the number of eye donations. And yes, maybe the things will happen and the changes will come for good. So thank you so much, madam. Thank you for that wonderful session. And with this, please allow me to present the certificate of appreciation for taking this excellent session on eye donation. See the world even after you depart, and you really made that saying come true during this organ donation and transplant symposium, DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. Thank you. Thank you so much, madam.
Thank you. Thank you.
Thank you. So now we move on to our next session, which we were supposed to take early on, but Dr. Gupta was busy in OT and so he could not join us earlier, and he has joined us now. So we move towards the liver transplant session. There are many clinical conditions which can irreversibly damage liver, for which may progress to end-stage liver disease. About 100,000 people in India die of liver failure every year. With liver having the capacity to regenerate, donated livers can come from either deceased donors or living donors. To tell us all about liver transplant, we have with us Dr. Gaurav Gupta. And I'll just share my screen and introduce him. Yes. So Dr. Gaurav Gupta is MBBS, MS, ASTS, multi-organ transplant fellowship. He has done. He's chief surgeon and senior consultant, liver transplant and hepatobiliary surgeries at Fortis Hospital, Mulund. He's abdominal organ transplant, liver, pancreas, and hepatobiliary surgeon who has received transplant surgery training from University of Pennsylvania, University of Pittsburgh, and UCLA. He has experience of performing more than 300 liver transplant as primary surgeon. He has been instrumental in establishing 3 liver transplant centers in Mumbai and Maharashtra from scratch. And before joining Fortis Mulund, he has worked in Fortis Escorts, Wockhardt Group of Hospitals, and Apollo Hospital. Warm welcome to you, Dr. Gupta, and the dais is all yours.
Thank you, Dr. Archana. Am I audible?
Yes, you are.
So, ma'am, I just have to share screen, right, to
Right.
start the presentation. Okay,
Right.
just. Can I see? Can you see my presentation?
Yes, I can see. If you can just make it full screen.
Yes, ma'am. There you go.
Yes.
Is it? Okay.
Absolutely.
Good afternoon, everyone, and I'm Dr. Gaurav Gupta, and thank you, Dr. Archana, and thank you, IMA, for giving this opportunity to talk. So actually, it was a nice, I would say, as Dr. Archana already told, I was busy in the OT, and the reason was a very noble cause, and for which today's session is there. So yesterday we had an organ donation from a very young person, 36-year-old. And the family was so enthusiastic. They agreed to donate all the organs. And because of that, today we transplanted a 22-year-old girl. She is waiting for transplant for last 1.5 years. So this girl is very intelligent, very smart. She is doing her pharmacology course. And she ended up in a kidney failure. And when they actually worked them up for the kidney transplant, they found she has a condition which is called primary hyperoxaluria. So it is a very rare condition where your kidney is damaged because kidney gets multiple stones. And the reason for these stones is high oxalate. And the reason for that is because there is a enzyme which is lacking in the liver. And that's why the kidney gets damaged. So these are very unique patients. So their liver is functioning normally. They have normal bilirubin, they have normal INR. They don't have the normal symptoms of the liver failure. But they present with only kidney failure. But you do a kidney transplant in these patients, the new kidney will again fail in few years. So these patients needs a liver kidney transplant. So very unique, and unfortunately, only mother was fit for the living donor for the kidney. We could not have any donor in the family for the liver. So that's why she waited for 1 year, and really, really happy we could do her transplant today. So these are the things for which we all basically were doing these sessions. And I'm going to come about actually yesterday's our experience. Very good experience and some little bad experience. But I'm going to talk about it at the end of my talk. And I think that is one thing which I think we as a fraternity, IMA, all can work out to make things better for the donor families. Okay. Now, before not wasting any time, I'm going to start my presentation quickly. So liver transplant. So see, we all talk about organ donation. Why we need organ donation? Because organ donation ultimately leads to transplant. And why transplant? Because people end up with the organ failures, whether it's a liver failure, whether it's a heart failure, whether it's like lung failure. Now, once they have a organ failure, these patients, any organs failure, they generally have a limited scope of life. We don't have any good machines or artificial mechanisms except for the kidney patient where they can go on dialysis for a few years. Other than that, most of the organs, once they fail, the patient has a very limited scope of life. So that's why the transplant comes in. When we're talking about transplant, transplant is a relatively young field, especially the liver transplant. The first transplant was done as early as 1967, and that was done by Dr. Thomas Stargell, who's considered the father of the transplant. Not only the liver transplant, father of the transplant. We talk about our country, the first successful transplant was done in 25 years ago. That was done in Delhi with Dr. Rashikar in Indraprasth Apollo Hospital. First few years, as it happens in any field, it is a time where people, we doctors are learning about these things, about our mistakes, and gradually the results improve, and then the transplant activity picks up. So it's only last 10 to 15 years where the liver transplant have become now a very standardized operation. The results are pretty good. It is happening in more than 10 to 15 states. It's still not happening in every state, but at least it's happening in all the big states, and the results have been pretty good. So this is Dr. Thomas Tarzer, who's considered the father of the liver transplant. Now, so not wasting any time. So why a patient needs a transplant? If you talk about transplant broadly, which patient needs a transplant? We can say 3 types of patient who needs a transplant. First, chronic liver failure. Second, acute liver failure. And third is liver cancers. So these are the patients who needs a transplant. So these are the 3 main indication. Out of these 3, 90% of the patient who needs a transplant are chronic liver failures, or which we call cirrhosis patients, CLD patients. These are the 90%. Rest 10% are either acute liver failure or liver cancer patient. Now, what is cirrhosis? As the name suggests, is a chronic liver disease where the liver gets damaged over a long period of time. Now, there are many diseases which can damage the liver. Ultimately, all these diseases leads to cirrhosis. And once the cirrhosis happens, it doesn't matter, it happens because of hepatitis, or it happens because of alcohol, or it happens because of fatty liver. All these cirrhosis patients behave more or less same. And this is an irreversible phenomenon. I mean, sorry, none of the therapies have been known to reverse the cirrhosis. So here, so that's why only, just the little bit about cirrhosis. As we talked about, there's a lot of things which can cause cirrhosis. Most commonly is alcohol, hepatitis B and C. Actually, the incidence of hepatitis B and C is going down because of very good medication for both B and C, and vaccine for hepatitis B also. Now, the thing which is coming up really in big numbers is called NASH. NASH is non-alcoholic steatohepatitis. It is self-explanatory term. So patient who does not drink alcohol, steato means fat, hepatitis means inflammation of liver. So it starts in patients who are diabetes, who are hypertension, who are obese, hypothyroid, all these lifestyle disease, which the incidence is going up. Now it starts with just fatty liver, and ultimately it leads to NASH cirrhosis. Lot of patient comes to my OPD, they keep telling me, sir, हमने तो कभी आज तक non-veg नहीं खाया, हमने कभी आज तक drink नहीं करी, smoke नहीं किया, फिर भी हमारा liver कैसे खराब हो गया? Because people have this misconception that liver is damaged only by alcohol. But if you look at them, their BMI will be 37, 38. They are diabetic for 10, 15 years. Blood pressure not controlled, cholesterol 300. So, sir, आपका liver तो खराब होएगा ही ना? So, all these things we need to understand. All these lifestyle disease, as they damage your heart or they damage your kidneys, they also damage your liver. And these are the patients, we are seeing more and more patients coming with this phenomena with NASH. So some of the uncommon are Wilson's, hemochromatosis, and autoimmune disease. Now we talked about cirrhosis definition. It's an irreversible scarring, and it becomes, the liver becomes nodular, shrunken, and hard. So this is how the liver, cirrhotic liver looks on pathology. If you do a biopsy of the liver and you see under microscope, the blue one is basically the fibrosis. So that tells you the liver is irreversible damage. The blue lines, that is means it's a portal bridging fibrosis, what we tell you. And this is how a normal liver looks and how a cirrhotic liver looks. This is a normal liver. The normal liver is smooth, edges are sharp, no nodularity, and this is how a cirrhotic liver looks. It is hard, that there is multiple, this irregular surface, nodular. The surface is not sharp, it is rounded. So this is how a cirrhotic liver looks like. Now, important thing to understand, not all cirrhotic patient needs a liver transplant. It doesn't matter if you have cirrhosis, you need a transplant. Which patient needs a transplant? So basically, If you talk about the objective criteria, there are certain scores. We don't need to go into too much detail about these scores. These are the online, there is a calculator available. You just remember the name is MELD, Model for End-Stage Liver Disease. There's an online calculator available. You just need three things, your bilirubin, INR, creatinine, and serum sodium. If you have these four values, any of the doctors can calculate the MELD score, and then it tells us how bad is the liver. MELD score is, if your MELD score is, this is the formula for the MELD score. It's calculators available. Any patient whose score is more than 12, they need a referral for the transplant. Your normal liver should have a MELD score of 6. Once your score becomes 40, that means if 100 patients have a MELD score of 40, that means 90% of the patient will die within 3 months. Within 3 months without transplant. So they are very sick patients. And anyone whose MELD score is more than 14 and 15, they needs a transplant. So that is the one criteria. The second important is what I told you is CTP. It's called child term criteria. This is the old score which tells us the severity of your liver disease. Again, very simple to calculate. Anyone whose score is more than 8 or 9 needs a transplant. Okay. Now, as I told you, cirrhotic patients, not all are needs a transplant, but once your cirrhosis worsens, then your lifespan become very limited. So to tell you in a simple terms, for a layman language, once you divide your patient into child A, child B, and child C. So 3 criteria. Child A patient, generally they live normally for 8 to 10 years. So they don't need a transplant as of now. They have a good lifespan for the next 8 to 10 years. Once you go into B stage, your lifespan goes down to just 2 to 3 years. And once you go into child C, generally most of them don't live for more than 1 year. So that's when the real urgency starts for liver transplant. Now, with cirrhosis, patient may have lot of problems. What are the problems? They can have ascites, they can have pedal edema, they will have kidney effects, they can go into hepatorenal syndrome, they can go to hepatic encephalopathy. Once these complications starts, the risk of mortality goes very high. So these are the patient who needs an early referral, who needs to be evaluated for transplant, and they needs to undergo transplant quickly. So that is the reasons once the patient's on the transplant list in a cadaver and they have getting these multiple infections, they have a very limited time for survival. That's why it's important to increase our organ donation so that the waiting list for transplant comes down so that we can save more and more lives. So these are the complications of cirrhosis, which we just talked about. And as I told you, initially it will be child A cirrhosis, go to child B, child C cirrhosis, and then if you don't transplant them, intervene them, they ultimately lead to sepsis and death. So one important, I think, message which I want to give to everyone is transplant remains the only therapy which offers the long-term survival. It not only improves your survival, it also improves your quality of life. I know a lot of my patients who were really sick, who had cirrhosis, who were not doing anything. They were sick and sitting at home. Once they undergo transplant and I see them after 3 to 6 months, I actually cannot recognize them. It's completely changed. They are back to work, they have gained the weight, even the skin color changes. The new hair comes. I mean, it's actually a new life, And if you ask any transplant patient, is this a new life which is given to them by someone who donated the organs? So we talked about the CND. The next, I told you 3 indications. The second indication of the liver cancer. In the liver cancer, the most commonly cancer is the hepatocellular carcinoma. And once the hepatocellular carcinoma develops, then a certain group of these patients who fulfills a certain criteria, for them, the liver transplant is a therapeutic options. So which are the criteria? Commonly used criteria, the Milan's criteria. Again, it depends upon the size of the lesions, how many the lesions. I'm not going to go into details, but that's how we determine which patient needs to undergo liver transplant. Same, there's other criteria which called the UCSF criteria. It again goes into the size of the liver cancer and the number of the liver tumors. This is how a liver cancer looks. Most of the liver cancers developed in a background of cirrhosis. This is another thing which is very important to understand. So you see, it's a cirrhotic liver, and that's a liver cancer. So for these patients, although we can do a liver resection, you can do RFAs, local regional control, but the therapeutic option remains the transplant. You not only take care of the liver cancer, it also takes care of the cirrhotic liver. So when you do a transplant, these patients do very, very well for in the future. The third indication we talked about is the acute liver failure. Now, what are the common causes of acute liver failure? Hepatitis A, hepatitis E. Yellow phosphorus is very common, especially in south part of the country and also in Maharashtra, in rural Maharashtra. This is the what we call the ratol poisoning. So, जो चूहे मारने की दवाई होते हैं, they contain yellow phosphorus, and they once you like people take them for as a suicide, and what it cause, it actually yellow phosphorus starts acting 2 to 3 days after you consume it. The patient does not get sick right away. So sometimes some patient relatives come, sir, हमारे बच्चे ने, हमारे relative ने yellow phosphorus ratol चूहे मारने की दवाई खा ली है 6 घंटे पहले, and तो generally क्या होता है कि वो लोग आते भी नहीं है क्योंकि patient is fine. The liver starts to get damaged from day 2, day 3, and once it starts to hit the liver, they don't give time. These are the very, very sick patients. The liver starts to fail within few hours, and transplant, if not done on time, this is very, very difficult to save these patients. The other common cause of acute liver failure is the paracetamol poisoning. In India, it's not that common. Paracetamol poisoning is more common in the Western countries. People take this as a, again, for the suicide measures. In India, हमारे पास तो सस्ते हैं, रेटॉल सस्ती चीजें हैं सुसाइड करने की, तो हम लोग पैरास्टामोल नहीं खाते हैं, तो it's not very common. The other comes some causes of acute liver failure can be drug induced, like for that tuberculosis drugs. So once these patients who had whether because of hepatitis A, hepatitis E, and they develop the liver injury, once the important test to know is INR. Once their INR starts to go up, these are the patients who needs, where we need to be really scared. People look at the, generally the doctors or look at the SGOT, SGPT, and they think, okay, SGOT, SGPT is high, it's coming down, so this patient will recover. But actually, SGOT, SGPT has no correlation with the liver injury. It is only the INR. It only test which is INR, and if you check for the lactate level in arterial blood gas. These are the only 2 tests which tells you how bad is your liver and whether the liver will recover with this injury or not. If the INR is going up, that patient needs to be counseled, and that patient needs to undergo transplant quickly, because once the INR starts to creep up, they go into the liver failure, and once the liver starts failing, the other organs also starts to get affected. So if the kidney starts to affect, lung starts to affect, then even with the transplant, it's difficult to save these patients. So just to summarize what we discussed till now, any patient cirrhosis whose MELD is more than 12, child score B7, B8, HCC patient or liver cancer patient, acute liver failure patient with rising INR. These are the patients who will benefit with a liver transplant. Now we know that organ can be sourced from the brain dead or the living donors. I'm going to skip these things a little bit. ZTCC, again, I'm going to skip these because cadaver donor, we already had a session about that. Yes, so I'm going to talk about the living donor. So liver is a unique organ. Why it's unique? So there are two special, I would say, the qualities of the liver which makes it very special. The first thing is we just need around 1/3 of our liver to survive, not more than 25%. Even if you have a 25% of healthy liver, that is sufficient for our body. All of our normal functions can be fine if we have just 25% of the liver. Rest of the liver, the nature or the God has given us just in case of an emergency. Rest, we don't need this liver. The second thing is, if you divide the part of the liver and take the part of the liver out, the rest of the liver grows back. And it grows back very fast. Within 3 months, it grows back to almost 90%. None of the organs, kidneys, heart, lung, you dissect a part of that organ, that organ never grows. Only the liver has this capability where we take even 60% or 70% of the liver from the donors, and the liver goes back to the normal. You do a CT scan in 3 months, the liver is almost to the normal size. So that makes a living donor liver transplant successful. Now, a little bit about this, some legality issues. The government has made this by the THO Act or THOA Act. Only the first degree relationship are allowed to donate. The first degree relationship have been very clearly defined. Only the 9 relations, where the 9 relations are in your generation, it will be your spouse, your real brother and real sister, not half brother, half sister, real brother, real sister, spouse. In your a generation ahead, your parents and your grandparents, both paternal and maternal. Generation below, your son, daughter, and grandson and granddaughter, both paternal and maternal. So these are the only relation who can donate an organs. So these are called the first degree relationship. It is not that you cannot donate an organ if you are a cousin or not. So those are called the unrelated donation, where we have to have a reason why the first degree relatives cannot donate, whether it is not matching, the blood group is different, or the liver is fatty. You need to have a reason why the first degree relation are not donating. Only then our authorization committee allows donation from the second degree relatives. So that is some legality about the living donor. That remains for both liver and kidney. Any living donor donation, the rules are pretty much same. So who are the patients who can donate? So donors from living, I'm talking about the living donors. So anyone from 18 to 55 years, no major comorbidities, they undergo CT scan and MRI and some anesthesia fitness. And once they get local authorization committee approval, then we can do a transplant. So this is just a picture how we actually look up a patient who can undergo transplant. So the CT scan is done, and then 3-dimensional a model is created about the liver, where we look at what are the blood vessels, how are the bile ducts, and where we have to divide them so that the donor does not get any problem. And even the part of the liver which comes out, that should be sufficient for the recipient. So this is how we plan for the living donor liver transplant. Just a couple of slides how we do it. So there are 2 teams working simultaneously. One team does the donor, one team does the recipient, and then we do the back table and then the implanted. This is how a cirrhotic liver looks. This is how the part of the liver this is a living donor. So we have taken the right lobe, right of the liver is out. You can see this is the cut surface. This is which was attached to the left part of the liver. So we cut the liver and we have put it in the ice and the solution. And this is basically a reconstruction on this. The white thing is a synthetic graft where we reconstruct the vessels, and this liver is ready for the implantation. And that is how a implanted liver looks. You can see the liver is very nicely perfused, pink. This was a space where the old liver was. The old liver is out, and this is only the right part of the liver, which is in the fossa. You can see it is attached here with this bile duct, and the arteries are attached, and this is how the liver looks at the end of the transplant. I'm just going to finish my talk here. Just a couple of slides about how they do them. Generally, the donor stays in the hospital for 1 to 2 days. Total hospital stays 7 to 8 days, and after then they can resume their work. For the recipient, the ICU stays anywhere from 3 to 4 days. Hospital stays 7 to 14 days. They don't need any isolation. They don't need any at the home any isolation rooms. Yes, in the hospital they need isolation rooms. First 3 months they need to be extra cautious about the infection, and after that they can go back to the work. The success is very good. It's almost more than 90% survival at the 1 year. At the 5 years, it's almost at the 70% survival. So just little bit about the COVID. COVID has affected all of us, and the number of the transplant has gone down, both cadavers and living donors. And but I think again the transplant activity has picked, the donation activity is picking up in last couple of months. So that is good. Madam, I'm over the time, or can I finish my talk, or do you think
so
I can
finish? You can finish.
Okay, sorry. So a couple of things about the myths and facts about transplant. So very commonly the people say once we have a transplant, do we need to live separately in a separate room? We cannot go out. So that's a complete myth. It is all precautions are first 2 to 3 months after liver transplant or any transplant. After that, they go back to the normal work. Actually, just because of the COVID, we tell them to wear masks. Once after 3 months, these patients, if there's no COVID, they used to not even wear masks. They go out, they can travel, they can do vacation, they go back to their normal work. So there's not any life is restricted. Yes, they need to take the immunosuppression, 1 pill in the morning, 1 pill in the evening, but they live a normal, healthy life. Difficult post-transplant care, again, I told you, it's just a matter of first couple of months. Once they cross that period, generally the liver does not bother them for the rest of life. Cannot eat or drink outside in the hotel. So yes, we tell them for first 3 to 6 months, be careful. But generally after 3 to 6 months, even we tell them, most of these patients, they even forget that they have undergone a liver transplant. So they go out, they drink water from outside, they have food at the restaurant, so they live a normal life. Medication are expensive, so lifelong the cost is around 5,000 to 7,000 rupees per month. So that is the cost of the immunosuppression for these patients. I don't know this is expensive or cheap, but I think any lifestyle disease, diabetes, hypertension, people end up spending this much of amount of money for the medication for every month. So that's the cost of immunosuppression. With a lot of generic drugs, actually the medication costs have come down drastically, and there are certain government hospitals where for the kidney transplant patients the medication are available for free of the cost. There are various NGOs. We have a tie-up with the NGO who provide medication at very cheap cost for the post-transplant patient who needs them. Okay, so again, basically, I'm just going to finish my talk here. And one thing I want to tell you that it is through the organ donation, through the effort of a lot of people that the transplant has become a reality. If there is no organ donation, transplant cannot happen. As Dr. Archana started with the talk that more than 1 lakh patient dies with a liver failure every year. That's a big number. And so it is not about these patients. The whole family gets affected. So I would say it's not 1 lakh patients, the 1 lakh families who gets affected every year, which is a preventable thing. The important thing is preventable. If we have enough organs, we can transplant out these patients, and these patients can have a normal life with a very good quality of life. So I'm happy to answer any questions. This is just our
Gupta,
yes, yes,
sorry.
please.
Please continue. Please continue.
No, I'm just finishing. This is with the Dr. Stazal. I was fortunate enough to be trained under the same institute where he was there. So just telling, he's the father of the liver transplant, and unfortunately he passed away 2 years ago. Yes, ma'am, please.
What is your say on these, people? There is in our Indian culture, there is, this that you should drink from the copper vessels. So I would like your say on this. What would you say on this?
So I'll just going to tell you one story before I go into the scientific reason for yes or no. So when I was in my school, my uncle, my father's very good friend, he ended up with complication like neurotoxicity. He was having dizziness. He actually had paralysis, and he was a MD physician. We tried our best, like he tried our best to know the reason. We could not find, and ultimately the reason was copper toxicity. It was very unusual. He belonged to a rural family. They used to, I'm not saying copper is bad, but anything should be in moderation. So copper, I honestly, I don't know what are the benefits of copper. Honestly, I would not, but I remember this story, and I cannot forget this thing. And simple things. He ended up on IVIGs. He spent tons of money. He checked because he had resources. He got it checked in the US, everywhere, and simple toxic tests, high copper, and that was his solution for the problems. So, so I'm not saying copper is bad, but anything should be in the moderation. It's not like copper is harmless. Wilson's disease, I'll tell you, Wilson's disease. So that, what are the Wilson's disease? Where, because the copper is not bind to the ceruloplasmin, and this copper can deposit in your brain, it can deposit in your liver, it can deposit in your cornea. So that you need to understand this.
So exactly. So that is the reason why I'm asking your take on it, that we have a, of storing water in the copper vessels and drinking from the copper vessels. So I would like to have your take on it. I mean, what is your recommendation? Because this can in rural India, rather I won't say even in rural India, even in urban India, drinking from the copper vessels, storing in copper vessels, it is a big part of lifestyle.
It has become a fad in urban India, not in rural India. So rural India, people used to have all kinds of vessels. They can be earthen vessels, copper vessels, steel, everything. But it's a fad in urban India these days. Copper is good. You go to a restaurant, they will the water is in the copper vessel.
Absolutely.
So I mean, again, I'm just telling you. So we have to understand that. So all these things. I mean, this. So I mean, I personally, I believe. That I mean, you don't know how long that water has been stored in the copper vessel. So that is one thing. So it's not about the water in the copper vessel, how long the water has been stored in the copper vessel. So probably
is there any position statement on this? Is there any position statement on this?
Ma'am, I honestly, I don't know, and I don't want to say something which is not scientifically correct. And but I personally don't recommend this. Personally, this is my personal recommendation. I don't go for these things. I think steel and the glass, these are the best things for drinking water, storage vessel. Even the earthen pots. The best thing is the earthen pots, if you ask me. जो हम लोगों के घर में घड़े होते हैं, घड़ा is the best thing. अपना गर्मी में ठंडा पानी भी करता है, and it is natural thing. So personally, I don't recommend these all copper vessels and all these things.
And how many cases of sorry, please continue.
So I think that is a very good question that you asked, and probably IMA would be a good thing, good platform where some of the we need to think about these things and kind of come with a statement what is good, what is wrong, because a lot of things are being propagated without any scientific basis, and in name of herbal, in name of organic, people are being fleeced. Trust me.
That is what my next question was, that how many cases of acute liver failure have you come across with herbal remedies?
Oh, I get a fair amount of cases, fair bit of cases. So I have got patients who are taking so-called homeopathy. I'm saying so-called because I don't know whether they were taking from the right person or not.
Authentic person.
Authentic. Yes. I've got so many patients who get liver injury because all these so-called homeopathy, they contain heavy metals, lead, mercury, and they damage the liver. Just recently, we had a patient, Indian origin patient, just last week. He came from Mauritius. Okay. Now this patient came to me for transplant. Sir, मुझे transplant कराना है. His bilirubin was 25-30, and he was diagnosed actually as a Wilson's disease in Mauritius. When we started examining him, I could not find a typical Wilson's disease. Then I started prodding him. Then he told me, sir, he had a COVID in February. After COVID, he drank a lot of these kadas. तो उसके घर वाले इंडिया से लेके जाते थे काढ़ा उसके लिए मॉरिशियस, और वो खूब काढ़े पिए उसने, और उसके बाद से इस bilirubin is going up, this is going up. Luckily, he did not end up in acute liver failure. This is what he ended up in, what is called DILI, drug-induced liver injury, and he stopped that and his liver starts to improve. But I do get a fair amount of patients who end up in acute liver failure with these so-called homeopathy medication, which has high lead and mercury content. So you need to be very, very careful about these things.
Absolutely, because why my point of asking this question was that even though we all are doctors, we all are still human beings, and we do tend to follow certain age-old traditions, and herbal medicines are considered a happy scenario even by our medical professionals without really knowing whether it is coming from an authentic source and whether the preparation is authentic or no. So that was my main point of asking you this question. There are two questions which we'll quickly take up. What about recipient's damaged liver?
So the recipient's damaged liver, the whole liver has to come out. So the liver, so it is called orthoptic liver transplant. Orthoptic means the liver, the new liver goes into the same area where the old liver was. The old liver which is damaged. So it is not like a kidney thing. Kidney, in a kidney transplant, you don't take out the kidney. Only in the few cases where the kidney is infected, you take it out. But in the liver transplant, the old liver which is damaged, the damaged liver is causing problems. So you have to take the old liver out and then you put the new liver in. The old liver goes for the biopsy, the whole explant. So you cannot leave the new liver in, the old liver. So if you leave the old liver, it will still keep causing the damage. So there is one thing which is called auxiliary liver transplant. Auxiliary liver transplant is a condition where patient has acute liver failure. But this acute liver failure, you expect if you tide over the acute crisis, this liver may recover. In this condition, we transplant a part of the liver. We leave the old liver behind. In the acute case, the transplanted liver takes over the function, and gradually the old liver, his original liver recovers. That is the only condition where we leave the original liver. Otherwise, we always take out the original liver and put a new liver in.
You have already said that it is the cirrhotics with a very high MELD score probably who will be needing transplants, but still there's a question, is fibroscan necessary pre-transplant? So just a quick answer.
So fibroscan is basically fibrosis is a condition which is it happens before the cirrhosis. So fibrosis is someone where cirrhosis you don't pick up. Cirrhosis you pick up only when the liver is permanently damaged. Before that, with fibroscan you can pick up whether liver is getting damaged, and if the liver is getting damaged, then you need to do the remedial action. So if you're drinking alcohol, stop it. If you're diabetes, hypertension, control it. So fibroscan does have a role, not in a transplant, but in a I would say like a healthy your yearly checkup.
Right, right. So I'm not going to go into this Ayurveda preparations and homeopathic preparations anymore. I think we have already covered that up, and it will be just repetition of questions. So with this, my sincere thanks to you, Dr. Gupta. You have been wonderful, and you have really cleared so many things about liver transplant, and you have almost covered everything about liver transplant. So a sincere thanks to you. And with this, just give me a second. It is a sincere pleasure to present to you the certificate of appreciation. Just one second, yeah. For taking this excellent session on all about liver transplant during Organ Donation and Transplant Symposium DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. Thank you very much.
Thank you, ma'am. Thanks a lot.
Yes, and with this, we move on to our second last session of the day. Please wait for the last session, because the last session is a very, very important session where we are going to talk about NTORCs, how you can register or how you can think of converting your hospital into a non-transplant organ retrieval center. That is our last session. And before that, we come to our second last session for the day. Caring for a new transplant organ and patient is a big responsibility, and there are many things to consider under this important heading. Post-transplant care includes recovery steps, anti-rejection medicines, mental health, vaccinations, and other health issues, and overall life quality after transplant. Acute rejection, primary non-function, and interferon are few of the important challenges. Infection are few of the important challenges. Post-transplant care is amongst the most important phase in transplantation medicine. To speak in depth about post-transplant care, we have with us Dr. Vrishali Patil. Please allow me to share my screen to introduce Dr. Patil. Yes. So just a minute. Yes. So Dr. Patil is multi-organ transplant surgeon at Dinanath Mangeshkar Hospital, Pune, performing both adult and pediatric transplant, living and deceased donor transplants. Her fellowships are she's trained from Henry Ford Hospital Transplant Institute, Detroit, MI, USA, and University of Wisconsin-Madison, USA in liver, kidney, small intestine, and pancreas transplant surgery. Hepatobiliary and pancreas surgery and vascular surgery training at North Manchester General Hospital, Manchester, UK. Specialization in liver transplant, intestinal, multivisceral transplants, pancreatic transplants, simultaneous pancreas and kidney transplant, islet cell transplants, total laparoscopic donor nephrectomy, single port laparoscopic donor nephrectomy, and complex hepatobiliary and pancreatic surgeries. On various boards, she's on various boards for transplant of ZTCC, Roto, Soto, and Noto. And she's specialty expert advisor to Transplant Committee, National Health Authority, Government of India. So with this, we present to you Dr. Vrishali Patil, and Dr. Patil, the stage is all yours.
Thank you very much, Dr. Archana Patil. I would like to thank the Indian Medical Association, Maharashtra chapter, for organizing this DAAN Fest and the Organ Donation Committee. Especially thanks to Dr. Suhas Pingle, President, IMA Maharashtra. And able to listen to me?
Your screen gets frozen intermittently.
How about now?
Yes.
Okay.
Right.
Important aspect of transplant management, but at the same time, a lot of I think fear, intimidation is amongst the transplant physicians, the transplant patients, the prospective recipients, and general medical groups as well. They're thinking it's something really complex, something that needs an ultra special environment and needs really super specialized management always. So let's go to some basics and important aspects of post-transplant care, and then go on to how can we do this in an integrated manner. Okay. So transplant surgery is unique in the sense that a diseased organ is taken or removed out and a new healthy viable organ is placed. And to maintain the functionality of the new healthy organ, to maintain the longevity of the healthy organ, immunosuppression is also part of transplant surgery, which is a different aspect as compared to any other surgery or any cardiac surgery or brain surgery or any general surgery that one looks at. It is unique as the patient's survival also depends if the immunosuppression is not very well managed. The goal of transplant or immunosuppression is that life after transplant should be as normal as possible, as healthy as possible, and the organ lasts as long as possible, free from rejection, infection, and any malignancies. In the first few days after transplant, the patient usually stays in a monitored intensive care unit or a specialized unit where the surgical aspects like thrombosis, bleeding, or collections are critically monitored. At the same time, how the new organ starts recovering from this infection is also important, or how the new organ does not have any organ dysfunction, how the parameters of its enzymes or other function tests are also critically monitored. The first few days, the drains, tubes which are placed in to drain out any collections, monitor any bleeding, or to look for any kind of pus discharges are also taken care of and gradually weaned off. Initial few days looks like tests pertaining to the organ implanted, like for example, in case of liver, the liver function test, in case of cardiac, the cardiac enzymes, the kidney function test, in case of pancreatic transplants, the blood sugar levels, and then of course, the induction immunosuppressive drugs are also introduced. These immunosuppressive drugs initially are T lymphocytic inhibiting agents like thymoglobulin or grapholol or antibody mediators like basiliximab. These injectables are given for the first few days and then later on tapered off to what we look at as maintenance immunosuppression. Once the surgeon and the physicians are satisfied that the patients are doing well, they are gradually transferred to the regular wards or rooms and then discharged. And when discharged, they are placed on what is called as maintenance immunosuppression. And herein lies the main crux of post-transplant management. The medications that are more commonly given for immunosuppression are tacrolimus, mycophenolate mofetil, and prednisolone. Now, tacrolimus comes in various brands in our country, but the most commonly used brands are from Pangraph, Prograf, or Wingraph. And these drugs, you can monitor that if these drugs are from good quality or maintaining good drug level by ensuring that the patient's drug levels are quite well and stable. Tacrolimus is a calcineurin inhibitor. It inhibits T cell activation and proliferation. Therefore, it inhibits interleukin 1, 2, 6, and 8. And this kind of inhibition leads to, by binding FK binding protein on the lymphocyte. And therefore, the immunity that the lymphocytes, T and B lymphocytes have against the newly grafted organ is suppressed, allowing the organ to thrive very well in the patient's body. Mycophenolate mofetil is the second round of immunosuppression that the patient has to take. It also inhibits proliferation of T and B lymphocytes in a different manner. It blocks the antibody production, therefore including the anti-HLA antibodies, the natural killer cells, and any delayed type of hypersensitivities which prevents chronic rejections. Steroids in the history of transplants in the 1940s has been one of the important drugs for immunosuppression. It blocks the inflammatory markers, it blocks the Th1 activating sites, cytokine inhibition, and therefore allows again the organ to remain healthy in the patient's body. How do we know that these drugs are enough or these drugs are doing their action? Is by doing regular blood test levels. So initially these blood tests are done twice a week, later on once a week, and then once in 15 days, and then once every month. These drugs have to be taken at particular timings. For example, tacrolimus are usually taken at 7 or 8 a.m., 8 p.m., while mycophenolate mofetil is taken 2 hours after the tacrolimus dose is taken. It is important that these drugs do not interact with each other and therefore do not interfere with their actions. Most of the patients have the myth that after a few months they can take these medicines at one go in the morning and one go at night, and that should be enough. If doing that, subjecting yourself to more risk of lower immunosuppression and therefore increased risk of rejections. So it is important that when a patient comes to you, that you ensure that the patients are taking the medications at the regular time intervals. Once the immunosuppression is adequately maintained, the other risks that patients are always go through are infections. In the first few months, bacterial infections are very strong, especially the gram-negative bacteria like Pseudomonas, E. coli, Klebsiella, Stenotrophomonas, Acinetobacter. With the T cell and B cell activity being reduced, these organisms can thrive easily. Secondly, we all know that infection can occur not just because of immunosuppression, but also because of comorbid conditions like diabetes, renal failure, obesity, which most of the transplant patients have been unwell for a long time and therefore are the harbinger or have colonized organisms within them. Thirdly, especially post-COVID, with the paranasal sinuses harboring either fungal infections or mucormycosis or aspergillosis in the respiratory tract, there's high risk of fungal infection immediately post-transplant in the first 6 months. Viral infections like CMV, EBV are also common because these are the infections which are commonly, or these viruses are commonly present in all of our bodies. I think there are only 10% of patients who are CMV IgG negative, while majority of us, if we are tested, we are CMV IgM negative, but CMV IgG positive. So reactivation of these viruses is very common after second to third months after transplant. So all these patients post-transplant, we place them on antibacterial like trimethoprim, sulfamethoxazole, which prevents nosocomial infections, and they are given these medications for about 6 months. Antivirals like valganciclovir is given in the tablet form, once daily dosing, to prevent reactivation of CMV and also to prevent any herpes zoster infections, which we commonly see in our Indian population. For organ transplants like pancreas or small bowel or lung transplants, we put them on azoles like fluconazoles, like a small dose daily, to prevent them from having any aspergillus or any fungal infections. Parasitic infections are less common nowadays. In the olden times, strongyloids and toxoplasmosis is very common. Nowadays, it's less common. Clostridia and other infections are more common in the Western population, less commonly seen in our population, probably with the amount of curd or yogurts that our population is known to use. So to prevent this from these infections from raising the heads and causing problems, we place our transplant patients on antibacterial, antiviral, and antifungal for the first few months. At the same time, it's important that they should be also vaccinated regularly, just like how we do for our children. The only thing that we don't do is we don't give them any live vaccinations. So we can give them any attenuated vaccinations like hepatitis B, hepatitis A, pneumococcal vaccines, influenza vaccines, and tetanus and diphtheria. These are to be given annually or every 5 years, or for in case of hepatitis B, once the antibody HbS titer is checked to see if it's adequate or less than adequate. Okay. The other thing that most transplant patients are vulnerable is that the risk of malignancy as compared to the general population is slightly higher in the transplant population. And therefore, it is important that every yearly or every 3 yearly, all transplant patients go undergo this tumor markers test assessment or ultrasonography, 2D echo, or ultrasound of the abdomen, pelvis, PSA, these kind of tumor markers. If the patient is more than 50 years of age, a colonoscopy every 5 years. If it's a lady, a mammography, to ensure that we are not missing out on any malignancy. Now, some of the common myths that patients have. First 2 months when the patient, it is very important that they take their medications at regular time interval. They follow up with the transplant clinic regularly. They stay fit, maintain physical activity, and they eat a good nutritious diet. When we say nutritious diet, it's just as a simple healthy food that we make at home. The Indian food has a mix of all proteins, carbohydrates, and fats. So you can eat everything as any other normal person can eat. There is no restriction in the type of vegetable to eat post-transplant. Some people try to avoid onions and lasuns, thinking there's something which inhibits it. These are all myths. You can eat a normal food diet with normal salt content. But it's important that you wash all your vegetables. You ensure that you keep your raw and cooked food separately. You cook your food well. Do not eat half-cooked meals. Ensure that your eating times are regular. Ensure that your medication times are regular. And drink safe water. Safe water need not be Bisleri water. Safe water is any drinking filtered water. If you don't have a water filter, drink boiled water. There are few things that one should avoid as a transplant patient. That is grapefruit and pomegranate. These fruits are actually, they're not bad in the sense that they cause harm to the patients, but they can interfere with the tacrolimus medication. Therefore, they can interfere with the tacrolimus levels in your body. And if your immunosuppression is erratic, then you are more at risk for rejection. And chronic rejection is an insidious thing. You do not see it in a day or 2 days or a week. It's after a few weeks you start seeing rise in the liver enzymes, a rise in your creatinine, and by the time you know it, the damage has already occurred. And what you were doing innocently, just eating healthy foods daily, not realizing that you're lowering your medication levels. So some common myths these patients have is that they need complete isolation for 6 months, do not come out of the houses, is absolutely wrong. What you need to do is ensure that whatever is your close family members, these are the only members that reside in your house. Don't bring your extended family members to come and visit you daily, like how we have a traditional cultural thing within the Indian population. People come to visit you. So ensure there's less to and fro of outside people coming in. The patient can use all the rooms, go and watch TV in the living room, eat food in the kitchen with his family, go back to his room, just remain clean and hygienic. They don't have to have separate washrooms or rent out separate houses. They don't have to have no furniture in the rooms except the beds. You're not creating a hospital. Just have a nice, clean, healthy room. That's all that is required. Their clothes did not be washed in Dettol, did not be washed separately. Just normal, healthy, clean clothes, clean food, clean water is water, and good ventilation. Avoid going to crowded places. That would be malls, that would be festivities, that would be weddings, where you are at risk of catching COVID or viral infections, tuberculosis, or any kind of bacterial infection. Again, just to show that you can even go for healthy walks daily post-transplant. You don't need to be in the room and just walking inside the room. Post-transplant care definitely involves monitoring to make sure the patient does not have rejection, infection, and disease recurrence. Therefore, you need to visit your super specialty center at least in the first 6 months. But it's also important that there is no rise in de novo malignancies, that there is no increase in obesity because a person just keeps on craving for food with the steroids that is there. Sometimes anxiety and depression because of the overwhelming emotions of guilt or organ donations. Or family has had somebody who's dead and then you got the liver, or somebody sacrificed their organ for you. Renal failure and cardiovascular disease, the risk is slightly higher because you're on immunosuppressive medications. The toxicity can lead to these problems. So go to your family practitioner regularly. Visit your transplant physician and transplant surgeon every 3 to 4 monthly after a year's time to ensure that your health is good. So the short and long-term post-transplant management, though complex, is very simple. It requires just a close follow-up and a multidisciplinary involvement. You need your infectious disease consultant. You need your regular physician. You need your surgeon to see if everything is okay. And you need a good annual health check to ensure you don't develop any comorbidities. So that's all I have to offer today. So thank you, Dr. Pate, for asking me to come here. I hope this was enough.
Oh, that was absolutely fantastic, madam, because that was the whole point of taking this session, that, as you said, they go back to their transplant physicians and transplant surgeons once in 3 to 4 years, but they do go back to their family physicians and the regular doctors. Meanwhile, whenever any other problems happen on day-to-day basis, and it is imperative that, all the doctors know what is to be done, because knowing individual organ transplants and care of individual transplants along with, that particular session is a different thing, and to look at the post-transplant care in its entirety, as a separate topic by itself, that I think cleared a lot of ideas in the minds of people. If there are any queries, we'll be happy to take it up. So are there any queries? Any queries? Yes. So I think your session was really so simple to understand, and it was so elaborated that I think the topic should have been well understood by people, and probably that's why we are not having any queries at this point in time. Thank you so much, Dr. Patel. It was really a wonderful session, and it gives me it gives me pleasure to give you this certificate of appreciation. Please give me a minute. For taking this wonderful session on post-transplant care during Organ Donation and Transplant Symposium DAAN Fest, organized by IMA Maharashtra State Organ Donation Committee on 11 September 22. So with this,
thank you very much.
Thank you so much, madam. I will just need a 1 minute break to talk to our next speaker. Give me a minute to get to him on phone. Yes. So sir is already in the session. Yes, so we go towards our last session, and one of the most important sessions, I would say, because just 1 second. Some echo. Is there any echo of my voice? Or is my voice clear?
Yeah. It's otherwise clear.
Okay. So setting up of NTORC, that is non-transplant organ retrieval centers, more in numbers will decide the future and will change the face of organ donation transplantation in India. India, with a population of more than 1 billion people, has only 300 hospitals. This is the figures that we could find. Sir, please correct us if I'm wrong. It has only 301 hospitals across the country that can perform organ transplants, even very less hospitals as organ retrieval centers. There exists just one hospital for about 43 lakh people that is equipped to conduct an organ retrieval and or transplant. And really, this number is really staggering. More hospitals should strive and become part of the organ donation movement and opt for augmentation of their facility as NTORC. This will prove as a milestone in organ donation transplantation medicine. For this, we have our expert speaker, Dr. Nitin Ambadekar, sir. Sir, just allow me to put forward his CV. Yeah, one second. Okay. So sir is MBBS, MD Public Health. He has diploma in hospital administration and he has done his PhD in public health. He has over 25 years of experience working in public health progressively at district, division and state level. He is ex-Joint Director Hospitals and Joint Director Procurement for Maharashtra State Public Health Department. And he is currently Director of Public Health Department, Government of Maharashtra, Pune. And we are also very privileged to have with us Dr. Yadav, Assistant Director Health Services, Thota in Mumbai, who has joined us today for this session. So, sir, a very, very warm welcome to you and thank you for taking out time to take this session, and the stage is all yours, sir. So you are made co-host, so you'll be able to share your screen.
Hello.
Yes, sir.
Yes, sir. Yeah, are you getting my voice?
Yes, yeah, I'm getting it, sir.
Okay, okay. Thank you. There may be there is some disruption. Actually, thank you for calling me for this session. Basically, there is no presentation because it's much of a topic for discussion and queries rather than telling you, because it's otherwise a simple topic. Only thing is the topic is very important. Yeah, because when we started 1995, so cadaveric transplant, it's one of the important aspects through which we can reach up to what is our expected, like those who are requiring the transplant. They at present the waiting list is so that like live donation will not be able to serve the purpose. And so we did make some progress. Like in 1996, there were almost only 2 cadaveric transplant, and in 2019, it was almost 242. So it's a quantum leap, though it's a very long period, but still it's very short of what we required, and waiting list is still there. So there are 2 basic issues in these areas, like they require more NTORCs to be registered and participate in all this process of organ donation. And there are definitely willingness of the hospital is more important aspect than the process of registration, because willingness, if you are willing, so I think there are not much hassle in getting registered for the NTORCs. In fact, Government of India, Maharashtra actually created one cell, and there is one dedicated all this activity. And I think Dr. Ado also has joined to this meeting, so that if there are any queries, that also can be definitely answered, because he is day to day looking after all this registration process. So in that case, like there are very few requirement of this any specialty hospital having some specialist, and OT and ICU can apply for this registration. Specifically, what we required for this is one of the RMP should be there, who will be the in charge of the hospital. One is the treating physician. There are some neurosurgeon, neurophysician is there, or we lower that criteria, even some intensivist trained physician, those who are like seen confidence to give the brain death certification shall be there. Then there is a ICU facility must be there. There's a good OT facility shall be there. Like OT facility may not be very modular type of OT, but at least it should have some lamellar airflow so that transplant team came and retrieve the organ. That should be have a proper OT for that matter. That hospital should be registered under Bombay Nursing Home Act. That is otherwise a very statutory and mandatory requirement for any hospital. So that is the same for when applied. And biomedical waste authorization. These are some of the basic requirements. If I had to just cut short in a nutshell, there are the team which should certify the branded. So that team need to be registered, and if that team is there, that hospital can register. Even sometime the branded committee of the transplant hospital to which will be shifting the organ after retrieval, that also can help in doing the readiness certification. So at present, there are some 65 NTOCs are registered under this Act of 1994, and we think many more will join. The most important issue is like once you apply to this Director of Health Services, because Director of Health Services is the appropriate authority for all registration under this Act. So it may be like transplant, retrieval, or tissue part of it. There are form number 13 for NTORC. There are form number 12 for transplant center and form number 13 for the NTORC. It's all given in the Act actually. So accordingly, that there are some basic requirements like surgical requirements, requirement of anesthetists, a physician requirement, ICU requirement, OT requirement. So that all are there. If your hospital with all these facilities are registered in the Bombay Nursing Home Act, so mostly those criteria are covered. So under this form, when you apply to this, then local team will visit the center and just check the whatever the requirement, whatever the form or application that you have submitted documents. They will verify accordingly, and accordingly form number 3, accordingly they will verify as per the documents you have submitted. Like form number 13 is the
Sir, you're not audible.
Oh. Hello.
We are losing your voice in between, sir.
Yeah. Now is it?
No, we are hearing you, sir, but in between your voice is being lost.
Maybe because actually I am in traveling to Pune for one meeting, another meeting.
Okay.
So little bit, yeah.
Right.
But I think I think I'll just repeat it. Like any multi-specialty hospital can apply for NTORCs. Okay. So then what we required is branded committee who will certify the that, and for that what we require is RMP of the hospital, which is in charge of hospital. We require treating physician, any physician or any specialist. Then we used to require neurosurgeon or neurophysician, but now any physician or surgeon who is willing and sick is capable of doing that, certifying, that is required. So this team is required. Then we required one ICU facility. Then what we required is the OT. OT may not be a very fancy type or modular, but it should be a standard OT with lamellar airflow. No. And then all these hospitals should be registered under Bombay Nursing Home Act, required biomedical waste authorization. All this information need to be filled in the form number 30, which is given in the Act of 1994. And accordingly,
when you submit this application to the Directorate of Health Services, Mumbai, that DHS Mumbai is the appropriate authority to register this cell. To this DHS, there is one cell particularly created in the Mumbai, Arogya Bhavan, that is headed by our Assistant Director of Health Services. At present, that is headed by Dr. Yadav, who has also joined this meeting. So whenever application came, we request our civil surgeon and team to visit that particular hospital. They'll check whatever you have mentioned in that form number 13. And if it is okay, so we can definitely register it as an NTORCs. There are 65 NTORCs at present registered in Maharashtra. And I think many more. So nearby that also can help to certify the brain death in that particular NTORCs. So that is also there. So, this is what is basically required. So what I think is, if you have any issues while registering, or anybody who has applied until now, or so it's better that, so that the things will be more clearer, simpler. And if any suggestions also are there from anybody, so we cannot change the act, but definitely what are the procedures, how can it be facilitated, we can definitely act on that. I think. Yeah.
Thank you so much, sir. I think this at least gives us some skeleton, some idea that it is not so difficult to become an NTORC. What is going to be needed is will and, the readiness to do something about it. The whole problem is this concept of NTORC is not known to many people. Second, even if somebody would want to become an NTORC, they really do not know how to go about it, where to approach, and what all things are needed. Third, as you said that, that there should be a team of ICU doctors who should be willing to certify the brain death certification. Yeah. So what I wanted to ask that, are there any trainings given, like if any hospital wanted to register as NTORC and they have their own physicians. So when they want to register for NTORC, are any training sessions organized for their physicians wherein they are trained into certifying brain death?
Actually, ZTCS members are there. They can definitely sometimes take the training for them. But otherwise, as such, from our side, there is not a specific training or some duration or certification is required. Training of physician is sufficient to.
So that is my whole point, because what happens is that brain death certification is definitely a very delicate topic. It is not something that any and every physician is going to be comfortable doing it. So if a certificate module is developed, or if if a proper training sessions are organized, probably this is what our suggestion would be, that we can definitely help you in getting people on board. But if any such certifications are, certificate courses are developed, then probably we'll be getting more physicians on board. And once more and more physicians are comfortable in learning about brain death declaration, and they are able to certify brain death patients, probably we will be getting more and more hospitals where they are associated, they would be willing to come on board for NTORC. My second question would be, yes, sir.
That is a good suggestion. I'll check also, and if it is possible, we talk with JTCC also. Otherwise, they are conducting some sort of training. Dr. Yadav will also can answer. Yeah, definitely, Dr. Yadav, you can answer.
I'm Dr. Arun Yadav, working as an assistant director for organ transplant at the state level. ZTCC and SOTO. ZTC means Zonal Transplant Coordination Center. There are 4 Zonal Transplant Coordination Center in the state of the Maharashtra. One is located at Mumbai, other is Pune and Nagpur and Aurangabad. These centers are mainly for the giving a training and creating awareness among the people for the organ donation. These are the institutions where the training facilities are there. They regularly conduct the training, and at the state level, this SOTO means the State Organ and Tissue Transplant Coordination is there, which is located at the Game Hospital, Mumbai. It also gives an impart training to those who needs a training regarding the brain death certification, regarding the cadaver transplantation, various organ transplantation cadavers. They conduct regular workshops. Now, at the as of now, the workshop is going on every monthly, every quarterly. The workshop is workshop training sessions are going on. So the training is not an issue. If if IMA gives some list of the people, those who are willing for brain death certification, we can arrange a training for them also.
Great, sir. Definitely we will work towards it, because this is what our suggestion would be, that probably this can increase a lot of people who will be willing to go in for registering as NTORC. If this brain death certification, is probably taught in a proper manner and people are able to do it in a proper manner, this being a very, very delicate issue. So second thing, sir, is there any compulsion on the number of beds for the NTORC?
No, as such, there is no any compulsion regarding the bed. Only thing, there's a hospital should have a operation theater facility, ICU facility, and the treating physician who is a registered medical practitioner, ICU intensivist, and the treating physician and surgeon. Now the neurology, as said by sir, neurologists and neurosurgeons previously were compulsory, but now you look at the form number 10 after Hla Act. The neurologist and neurosurgeon, if neurology and neurosurgeon is not available, any surgeon or physician or anesthetist or intensivist nominated by a medical administrator of the hospital can approve or can give certify brain death. So this can be approved by the state approved authority also.
Okay. Sir, my next question is, do these hospitals need to be NABH accredited or accredited by any other council?
No needed, not needed.
Okay. Great. So, sir,
only should be registered under Bombay Nursing Home Act.
Yes, absolutely. That is, I think, primary requirement.
Biomedical based authorization certificate should be there.
So basically, anything and everything that is needed to be registered under Bombay Nursing Home Act, I mean that I think everything, all these things automatically get covered. Biomedical waste authorization, fire NOC. So all these things, they automatically start coming into the picture. So what I wanted to know is that, is there any accreditation of any council is required? So you rightly said no. Sir, IMA would be very much willing to work hand in hand with the government, because there is definitely a lot of apathy. There is lack of awareness. More than apathy, I would say there is lack of awareness, and there is a fear of getting stuck into the legalities. Because with the increasing number of violence on doctors, organ donation is one time where we are talking about talking to the relatives of thinking that the patient who is on ventilator, that person should be considered as brain dead and should be considered further for organ transplant. And this is a very, very sensitive and delicate time where the emotions are running very, very high, and it needs to be tackled at a multi-level. So I think there are many, many factors which start coming into play when we talk about these things. And if we can formulate a strategy, IMA will be always there to support you, but I do not think it is a very difficult, or rather I would say difficult task, but not impossible task, that we can work on training of centers as NTORCs, training of physicians as certified physicians who can certify brain death, certifying or rather training the surgeons, as at least retrieval surgeons, transplantation is an entire different aspect of it by itself. So if these things are worked together, then probably we can do at least something better than what is happening. So this is what my say is, and this is open to comments from your end. If Sir Dr. Yadav or Dr. Ambadekar sir has any suggestions to give to us as IMA, we will be more than willing to help for anything.
Only thing, one point which I just like to add is there's a problem. What you said is true, that there's so many factors because of which the people are like not interested in joining or doing this. But what I suggest is these are all like anecdotal, or what may say is what you hear says or you discuss among your colleagues, then these things come up. But IMA must be having the list of hospitals which have this set of facilities available plus specialists available. Then you can send some sort of a checklist to them or something sort of a questionnaire and get the information why these people are like not able or declare the brain dead, and then in this chain of this transplant, systematic information is gathered. That is good. So also think in that proper angle we can ZT there are so many people like willing to but what we require is, if this systematic information is there, then it's a bit easier to draft a policy regarding.
Yes, sir. Sir, what we will do is, you have given a very good suggestion. We will start a questionnaire from our end. We will, request our members to, if you can give us some pointers as what all things will help you in probably coming out with certain different things. We'll add it in that questionnaire. We'll make that questionnaire, even share it with you. If I can get Yadav sir's this thing, I'll share it with him. And if you can give us some pointers as to what all things you will need for people to answer, which can probably guide us better towards, aiming at some difference in some different policy making or something which can help in improving the outcomes. So we will definitely go ahead with that, and we'll get back to you with whatever the answers we get from the questionnaire. We'll definitely do that, sir.
Yes. Okay. Thank you. Thank you.
Thank you. Thank you so much, sir. And thank you, Ambadekar sir. Thank you, Yadav sir. It has really been an honor to have you here on our platform. And it was wonderful listening to this. And I'm sure we will do something better. And with this, we come to the end of today's session. And I cannot thank the delegates who have, stayed back with us till the end of session and been with us throughout this symposium. Dr. Milind wants to ask something. Dr. Milind, do you want to ask something?
Hello.
Yes.
Are you getting my voice?
Yes, yes.
If a MBBS person who worked in public health for 38 years, can he be in a team for certifying brain death or other issues? Hello.
Yadav sir, Ambadekar sir.
Why not? Why not? He's a registered medical practitioner.
Yes, sir.
He's a treating doctor. He can certify. If he's a
yes, sir. Yes.
If he's able to do it, why not?
Yes, sir. Thank you.
Right. Any other questions anybody would want to ask? We have experts over here. If anybody has got any doubts, any queries, please do ask. Okay, so this brings us to the end of today's session, and rather the part, once a session goes very well, this is the part I most enjoy, and that is valedictory Thanksgiving. So with this, we come to the end of today's session, and it gives me immense pleasure to thank the people who have been instrumental in making today's symposium a very big success. My sincere thanks to IMA Maharashtra State President Dr. Suhas Pingale and Honorary Secretary IMA Maharashtra State, Dr. Mangesh Pate, for the support and confidence. All esteemed guests today, Dr. Nitin Ambadekar sir, Dr. Arun Yadav sir, Dr. Sujata Patwardhan madam, Dr. S. Narayani, Mr. Santosh Marathe, all the speakers today, Dr. Akshay Chalani, Dr. Rahul Pandit, Dr. Satish Javli, Dr. Gaurav Gupta, Dr. Ravindra Nikalji, Dr. Sanjeev Jadhav, Dr. Gaurav Chaubal, Dr. Shilpa Joshi, Dr. Vrishali Patil, and of course, once again, Dr. Nitin Ambadekar sir and Yadav sir. Sincere thanks to Dr. all past presidents of IMA Maharashtra State, Dr. Ashok Tambe sir, Dr. Milind Naik sir, Dr. Arun Pavade sir, Senior Vice President IMA Maharashtra State, Dr. Prakash Marathe sir, IPP Dr. Londe sir, President-elect Dr. Ravindra Kutte sir for joining the session and giving us encouragement. Sincere thanks to Fortis Hospital for educational assistant to sessions of Dr. Satish Javli and Dr. Gaurav Gupta. A big thank you to Apollo Hospital, Navi Mumbai for their educational assistant for lectures of Dr. Ravindra Nikalji and Dr. Akshay Chalani. To Global Hospital Parel for educational assistant with session of Dr. Gaurav Chaubal, ACCP West Zone, and Dr. Shantes Kaushik for assistance in organizing lecture of Dr. Sanjeev Jadhav, and HV Desai Eye Institute and Dr. Rahul Deshmukh for organizing lecture of Dr. Shilpa Joshi. Thanks to Dr. Tushar Dige for helping with Dr. Vrishali Patil's lecture. My sincere thanks to marketing team of Fortis, Mr. Chetan Surani, Mr. Balwant Singh, marketing team of Apollo, Mr. Vishal Tukrul, Mr. Sandeep Pategar from Global Hospital Parel. IMA Maharashtra State Organ Donation Committee advisors Dr. Arun Halbe sir, Dr. Anil Suchak, members Dr. Prashant Devre, Dr. Vijay Shivpuje, Dr. Sheetal Mahajani, Dr. Niti Upasni, Dr. Ananta Kulkarni, and Dr. Vaishali Khandait. All the wonderful delegates who are here since 9 o'clock in the morning and who have listened so patiently to all the sessions. Without you, it would not have been possible. And finally, I am a Maharashtra State office staff who have been giving us back-end support, Betsy and Ashwini. With this, we come to the end of today's symposium, DAAN Fest, the virtual organ donation and transplant symposium. And thank you once again, everyone, for being with us and making this program a grand success. The recording of this program will be available on YouTube channel Teen Talk, TEENTALK, and whoever has registered with us and we have the mail IDs, we will be even mailing you the links of today's program, the recording of today's program. So with this, and of course, for the MMC credit points, the MMC credit points will be allocated to people who have registered, who have filled the Google form with us, and we have the registration number. And of course, if they have attended the session, because we have taken screenshots at various intervals, and they will be matched, the attendance will be matched with the Google form registrations, and you can check the MMC credit points. 2 MMC credit points were granted for today's session, and the credit points will be uploaded on your web page. You can check it if they have been uploaded in your web page after 1 month's time, because it is a long process and it takes time for the points to reflect in your account on MMC web page. So with this, thank you everybody. Wish you a very, very good day, and till we meet next, thank you so much. Thank you so much for joining.
Thank you. Thank you.
Thank you.
Thank you.